of pain, just a last slide, oligoarticular or polyarticular pain, distribution of joint involvement like symmetrical in rheumatoid and lupus, asymmetrical in psoriatic arthritis, spondyloarthropathy and gout, and involvement of axial skeleton like in ankylosing spondylitis, osteoarthritis, rheumatoid arthritis. So this is a history and physical taking examination of slide. We should see if the patient is of articular pain is of more than 6 weeks, less than 6 weeks, chronic, acute pain, osteoarthritis, rheumatoid arthritis. So the monoarticular and oligoarticular pain in septic arthritis, crystal arthritis, psoriatic, juvenile RA, and polyarthritis in acute and chronic, as I discussed before. So the last few slides of just the picture, these are the classical hand deformities in osteoarthritis and knee deformities. This is the X-ray where there is loss of cartilage, lack of loss of cartilage in osteoarthritis. X-rays we daily see in a lot of our patients. So these are the deformities, swan neck deformities. So these are the extra-articular manifestations of RA. And the last side is of, so we should know how to differentiate between arthritis and arthralgia. ESR, CRP and X-rays are the key in workup. Age, pattern of involvement, other symptoms are important. Rule out the emergent thing first. Joint aspiration is sometimes very helpful in the diagnosis. Thank you very much for patience listening. And I will Mike, sir.
Many times we got cases when we have classical swelling and pain of grade 2.
Swelling and pain in?
Grade 2.
Yes, yes.
Sudden onset, mostly in the night.
Yes.
But when we go and work up for the blood investigations, the uric acid is near normal, 6, 7, 8 little high.
Yes.
So how to approach and at what level we should consider to start that for the uric acid medications?
Yes, sir. So the first of all, we should see what's the age of the patient. Of course, as I discussed in the first case, male, female, any history of hyperuricemia in the family, and if it is a classical grade 2 swelling, patient is presenting with the cardinal signs of inflammation, severe pain, excruciating pain, then definitely it's a crystal arthritis. Undoubtedly, it could be gouty arthritis, which should be the first diagnosis, especially if it's an obese patient, diabetic and other metabolic syndromes would be there. And if you are saying that the uric acid is high, 8 is definitely high, and we should straight away, we should not, of course, if the patient is coming to us with acute gout, we should not start just the hyperuricemic drugs. At least we should start at least after 2 to 3 weeks. First, we have to control the acute inflammation with the NSAIDs, colchicine, if required intra-articular steroids, and then after 2 weeks, we should start controlling. We should start the febuxostat or whatsoever drug you are planning.
So we should start the febuxostat straight away, or
no?
We have to wait? No.
So yes, so that's what I always say in my presentations also. We should not start upfront uric acid febuxostat on day 1, because sometimes if we start on day 1, it may lead to migration of the crystals and it may precipitate the attack. It not only just control the uric acid. So एक डेढ़ हफ्ते बाद भी start कर सकते हैं, करना ही चाहिए, but at least I wait for 10 to 12 days minimum.
One more question. Uric acid का level high किसको माने? 8 को, 7 को?
Sir, so this is another very important question. Not 8, not even 7. So if the patient is having a history of hyperuricemia, जैसे 8 है, किसी को 9 है, and if he is on treatment, if the symptoms are not controlled, then even the uric acid of 5.5 or 6 is not considered as a normal uric acid. So sometimes ऐसा होता है कि आपके पास भी patients आते हैं कि he is on febuxostat or allopurinol, uric acid is 5.56, but suddenly he again develops an acute of so we have to not treat the lab reports, we have to treat the crystal burden. So crystal burden कम करने के लिए we should target uric acid in such patients at least 4 to 5 also who have the previous history. Yes. Absolutely, sir. So sir, 10 to 12% of cases of chikungunya, they may progress to chronic inflammatory arthritis like rheumatoid arthritis, or what we call as post chikungunya rheumatoid arthritis, PCRA. So they may progress to PCRA, and 40 to 50% cases may have myalgias and arthritis, myalgias and arthralgias for even from months to many years. Like जो 2006 में फैला था चिकनगुनिया, उसके अभी तक we are seeing patients of myalgias. 2006 में चिकनगुनिया जो है 16-18 में जो फैला था, they developed rheumatoid arthritis like symptoms like severe excruciating pain in hands and multiple deformities in seronegative arthritis type of picture. Sir, the diagnosis is clinical, absolutely, with raised inflammatory markers. History of chikungunya is there. Patient coming to us with severe joint pain, severe pain. All anti-CCP is negative, RF factor is negative. Yes. So management is just like rheumatoid arthritis. What I start for chikungunya arthritis is hydroxychloroquine, sometimes methotrexate, and absolutely if the pain is severe, then low tapering dose of steroids.
What is the maximum dose of methotrexate while treating the rheumatoid arthritis?
Yes, sir. So the 25 milligram per week is the maximum dose recommended, up till 25 mg, that's it. But not to start upfront because methotrexate is the most untolerated drugs. So I start with 10 mg per week or 15 mg depending on the age and weight of the patient, and gradually I escalate.
Dr. Akshay, most of the patient comes to us with the polyarthritis.
Yes, sir.
And they have, it is correlated with this arthropathy,
Yes.
with the hyperuricemia induced.
Yes.
Or it is because of asymptomatic hyperuricemia, other causes of the arthropathy.
So sir, polyarticular gout is a very, very rare thing. So it, as per your patient, he or she definitely may be rheumatoid arthritis or some another type of inflammatory arthritis, but not gout. It could be asymptomatic hyperuricemia and with some other polyarticular presentation that we need to rule out. So polyarticular gout is a very rare thing. Okay. Thank you very much. Thank you.
Thank you, Dr. Akshat, for the wonderful session. I would now request our speaker and chairpersons to please be there outside the hall at the reception podium for the felicitation ceremony. Our next scientific session is on nephrology. In nephrology, the numbers may look complicated, but the approach begins with simple fundamentals. Using creatinine, falling urine output, proteinuria, hematuria, electrolyte imbalances, abnormal ABGs can often present with diagnostic challenges to our nephrologist. Our next speaker is a dedicated expert in renal health and critical care. Dr. Rohit Khandelwal is a consultant nephrologist at Birla Institute of Medical Research and has around 8 years of experience in clinical nephrology and research. Without formal ado, let's welcome Dr. Rohit Khandelwal, sir, to share his insights on the podium, basics while dealing with a nephrology case. Sir, the mic is all yours. I would now like to invite as a chairperson Dr. Sanjay Rana sir, Dr. R.K. Gupta sir, and Dr. Rahul Gupta sir to please come to the stage as a chairperson. Sir, please.
Good morning, everyone. So, first of all, I am thankful to IMA Morena for inviting me as a guest lecturer. So, when I was given the this big responsibility of what to deliver lecture on, so I just asked my physician and surgeon friends that क्या प्रॉब्लम आती है नेफ्रोलॉजी केसेस में. बोले इलेक्ट्रोलाइट्स मैनेज करने में दिक्कत है. मैंने बोला ओके. सो आई टुक माई फर्स्ट पार्ट इलेक्ट्रोलाइट्स लाइक सोडियम पोटेशियम, जो सबसे कॉमन चीज़ हम नेफ्रोलॉजी केसेस में देखते हैं, तो उसको मैनेज कैसे करें. द सेकेंड, द अपडेट्स एंड द गाइडलाइंस अबाउट द हाइपरटेंशन एंड नेफ्रोपैथी, एंड द लास्ट पार्ट ऑफ माई प्रेजेंटेशन वुड बी ऑन किडनी बायोप्सी. किन पेशेंट्स को किडनी बायोप्सी के लिए हमें रेफर करना चाहिए. So, sodium problem is not actually a sodium problem, it is a water problem. So, sodium is that electrolyte which is also called an effective osmole. So, effective osmole is one which does not move between the intracellular and extracellular compartment, but yes, if it is present in high quantity, then it definitely asks water to come along with it. So, whenever there is high sodium or low sodium, it actually is playing with the plasma osmolality. So if the plasma osmolality increases, we produce concentrated urine because the osmoreceptors in the hypothalamus, they just stimulate our thirst and increase the secretion of the vasopressin. So, so that is how we produce a concentrated urine, and the reverse happens if the plasma osmolality goes down, then we produce the dilute urine. So if there is any defect in producing the concentrated urine, we develop hypernatremia. If there is any defect in producing the dilute urine, then we develop hyponatremia. So this table on the right, which on the left there are some certain molecules like urea, ethanol, ethylene glycol. So these molecules are actually ineffective or non-osmotic electrolytes, which increases the plasma osmolality, but they do not cause increase but they do not cause decrease in the sodium. So these are ineffective osmolytes. On the right, like if there is high glucose level, if the patient is given mannitol, glycine, maltose, these are effective osmolytes, and these are also the causes of translocational hyponatremia. Translocation is what? If these molecules are actually effective osmolytes, say, so they can not move between the intracellular and extracellular compartment. So wherever it is present, it will just attract water with it. So that is why we see translocational hyponatremia with these molecules. Now the drugs associated with hyponatremia, so it could be the desmopressin, which is the vasopressin analog. It could be because of NSAIDs or paracetamol, which potentiates the renal action of vasopressin. It could be because of SSRIs, nicotine, narcotics, or carbamazepine, which enhances the vasopressin release. And there are certain other drugs like haloperidol, fluoxetine, ecstasy, IVIG, which causes hyponatremia by unknown mechanisms. There are certain other drugs, especially the antihypertensive drugs like ACE inhibitors or ARBs. And the thiazide diuretics like metolazone, chlorthalidone, hydrochlorothiazide, these also cause hyponatremia. Now, we have to first see in hyponatremic cases whether the patient is genuinely hyponatremic or not. So we have to rule out the pseudohyponatremia, which we see in cases if the patient has paraproteinemias or high lipid levels. Second part is we have to measure the plasma osmolality, whether the patient is genuinely hypotonic or not. So like if the patient has hyperglycemia, radio contrast is given or mannitol is given, these patients can have hyponatremia, but usually the plasma osmolality is high. The third part we have to see is what is the urine osmolality. So if the patient is able to dilute his urine, and the urine osmolality is going down, that means there is no diluting defect. That means the patient is either consuming high quantity of beer or is a primary polydipsic patient. So these are the causes of non-AVP mediated hyponatremia. Okay, so if there is, the next part is what is the AVP mediated, that is the vasopressin mediated. If the patient or if the patient's kidneys are not able to dilute urine and the urine osmolality is still high. So for that we have to also assess the extracellular volume, that is the fluid status of the patient. If the fluid status of the patient is going down, that means the patient is either losing the water because of GI fluid loss, the patient is on high dose of diuretics, it is because of burns or third space loss. If the patient is euvolemic hyponatremia, then the causes are, most common is the SIADH, other causes could be the severe hypothyroidism, glucocorticoid deficiency, etc. Also in marathon runners who ingest large quantity of water while doing that activity. And if the patient has hypervolemic, that is the extracellular volume is high, then these patients would be the cause of, the causes could be cirrhosis, nephrotic syndrome, or congestive heart failure. Now, if the patient develops acute hyponatremia, that means that patient can develop symptoms. Mostly the patient develops the brain symptoms. So the reason behind is that because the sodium level is going down acutely, so brain is not able to adapt to that new osmotic equilibrium. So in chronic cases, usually the brain loses its osmolytes like taurine, glutamate, electrolytes, and it adapts to the new osmotic equilibrium. So in chronic cases, we do not see symptoms. But if the patient's sodium level is going down very rapidly in less than 48 hours, then these patients develop symptoms. Now SIADH. So what is the diagnostic criteria for SIADH? So as I mentioned, the essential criteria is if the plasma osmolality is low, urine osmolality is high, patient is euvolemic, urine sodium is elevated and there are absence of other causes like thyroid, adrenal, pituitary or renal insufficiency, then this clarifies for the diagnosis, clarifies for the diagnosis of SIADH. Other supplementary criteria could be the hypouricemia, the abnormal water load test, if the serum vasopressin level is inappropriately high and sodium is not getting corrected despite giving fluid. So in such cases, we have to use the fluid restriction to manage SIADH. Now the treatment. So the common mistake which everyone does is, as soon as we see a low sodium level, we try to give 3% saline to each and every patient. The fact is we have to give 3% saline only if the patient is symptomatic, otherwise there is no need to give. Most of the patients are managed very well with the water restriction, and if required, then we can give V2 receptor antagonist, that is the tolvaptan. And we have to ask patient to take good or high protein diet to correct the sodium level. If the patient is symptomatic and if the duration is less than 48 hours, then we have to treat with 3% saline at the dose of 1 to 2 ml per kg per hour, but the correction rate should not be more than 8 milliequivalent per day. If the patient is chronic hyponatremic and if the duration is definitely more than 48 hours, we still have to correct it, but we have to see whether as soon as the patient becomes asymptomatic, then we can stop 3% saline in such cases, and then we can very well advise patient to take high protein diet and the water restriction. And definitely we have to check for the urine osmolality, urine electrolytes, serum sodium regularly, at least 12 hourly in all these cases. Now hypernatremia. Hypernatremia is exactly opposite. So there is a defect in the concentration of the urine. So again, in such cases, while approaching these cases, we have to assess the volume status of the patient. If the problem is here the water, it is not the sodium, it is the water. So in hypovolemic hypernatremia, the total body water has actually gone down. It has gone down more than total body sodium. So the next investigation in such cases is the urine sodium. So if it is less than 20, it is the extrarenal losses, like because of diarrhea, fistulas, burns, or insensible losses. If the urine sodium is more than 20, then the cause is the renal losses, or maybe the patient is on high dose of diuretics or diabetes insipidus. The third is the hypervolemic, where the total body sodium has actually increased more than the total body water, and these cases, for excreting this sodium out of the body, you have to use the diuretics like furosemide or thiazides to treat such cases. And in all such cases, the urine sodium is always high. Now, the management. So if the patient is hypovolemic hypernatremia, we have to correct the volume deficit first. So in such cases, we have to administer the isotonic saline until the hypovolemia improves. And as soon as you correct the volume deficit, then you have to correct the water deficit by administering the half normal saline, dextrose 5% or plain water. If it is a euvolemic hypernatremia, we have to just correct the water deficit. So you have to give hypotonic half normal saline or 5% dextrose or oral water. And if the cause is central diabetes insipidus, then you have to use the aqueous vasopressin in such cases. In hypervolemic, you have to use the diuretics and you have to discontinue the agent which is causing the hypernatremia. Now, hypokalemia. Hypokalemia we need to treat fast because the patients develop symptoms and the worrisome symptoms which can actually be life-threatening to the patient. So while evaluating hypokalemia, first we have to rule out is the pseudo-hypokalemia, which happens if there are abnormal leukocytes present and if the sample is not stored properly in if the storing temperature is high, if the sample is stored in the heat. Then the second, we have to check for the redistribution, whether the patient is given any recent insulin, high dose of insulin, any theophylline, if there is elevated aldosterone level. We have to also look for the non-renal potassium loss. So urine potassium, it should be, if it is less than 20, then it is a non-renal. If it is more than 20, it is a renal potassium loss. So non-renal potassium loss, the causes could be the excessive fluid loss from the skin or from the GI tract. If the potassium loss is from the kidneys, then we have to see whether on what drugs the patient is on. So if the patient is on high dose of diuretics, aminoglycosides, if the patient is having bicarbonaturia, which we see in renal tubular acidosis patients, if there is metabolic alkalosis, if there is hypomagnesemia. Hypomagnesemia is very common, so one should always check for magnesium levels if the patient is having hypokalemia. So these could be the causes of renal potassium loss, but in all such cases, the blood pressure is is usually lower down. If the blood pressure is high and hypokalemia is present, usually the causes are some endocrine disorders like Liddle syndrome, in which the aldosterone level is low but the cortisol level is normal. If the cortisol level is high, then it is definitely a Cushing syndrome. If the aldosterone level is high, it is a hyperaldosteronism syndrome. And the last, the genetic disorder which causes hypokalemia with normal blood pressure, low blood pressure, is the Barters or Gittelman syndrome. Now, the treatment. So, if the patient has developed life-threatening complications, we have to treat at a very fast rate. So, we have to give 10 milliconate of casein in 15-20 minutes, and as soon as the potassium or the life-threatening complications resolves, you can very well switch these patients to oral potassium. So, we have to choose the potassium preparation, like if the patient is able to take the oral Potlo, then we can give oral Potlo. So, the Potlo is like if you give 10 ml of Potlo, it provides 15 milliequivalent of potassium to the patient. So, depending on the patient's oral intake, and if the patient's bowels are functioning and the serum potassium is more than 2.5, then you can use the oral. Otherwise, you can use the IV potassium in such cases. IV potassium, the correction rate is still, it should not be more than 10 milliequivalent per hour. Now the hyperkalemia. So hyperkalemia, what we see usually is that most of the time the cause is the drug. So most commonly the drugs which we are using in our day-to-day practice, like in hypertensive patients, we are using ACE inhibitors or ARBs. If the patient is given aldosterone receptor antagonist like fenrenon or exaceron or spironolactone, if the patient is on potassium sparing diuretics, if the patient is on NSAIDs and COX-2 inhibitors, these are the common drugs which we are using in our practice, and these all drugs can cause hyperkalemia. In transplant patients, if the patient is on cyclosporin and tacrolimus, that also causes hyperkalemia. So, while evaluating hyperkalemia, we have to first see the ECG, whether if the patient has developed any ECG changes. So, you have to treat these patients like very fast, and sometimes in these patients, if the ECG changes are present, I guess the most effective treatment would be to do dialysis of such patient. Dialysis would be like in 2 hours the potassium will come down to normal. And while evaluating hyperkalemia, we definitely have to rule out the pseudo hyperkalemia. If the sample is hemolyzed, then we have to rule out that. Further evaluation is based on the history and laboratory. So if there is history of dietary potassium excess, if the patient has a history of metabolic acidosis, is a patient of CKD, there is any obstruction present in the urinary tract, these all are the causes of hyperkalemia. The treatment of hyperkalemia, we all know that we have, for antagonizing the membrane effect, then we have to give the IV calcium. For increasing the cellular uptake of the potassium, we have to use the insulin along with the dextrose for 50%. So not in every patient the dextrose is to be given. If the serum glucose level is more than 250, then you can directly give insulin without giving any dextrose 25%. If the glucose level is less than 250, then you have to use dextrose with insulin. Other is the nebulization with the albuterol, which also causes the cellular uptake of potassium. Now the potassium removing drugs are the calcium polystyrene sulfonate, which comes in the name of K-Mind. Sodium zirconium cyclosilicate is recently available in the name of Localma. These are very effective drugs, and if these drugs are not working, then the last resort is the dialysis, which is the most effective way to reduce the potassium. Now my second part of the presentation is the hypertension and nephropathy. So all the major guidelines have, they align on a definitive target of less than 130/80 for most patients, and KDIGO has given a target of 120, less than 120, because they rely heavily on the SPRINT trial. So when we critically analyze the SPRINT trial, it was actually, they used unattended or automated office blood pressure, which yield lower readings than the standard clinical settings by approximately 10 to 15. They excluded the diabetics and proteinuric patients, so it is very difficult to generalize these results on every patient. And most important part, it did not demonstrate any significant benefit for primary kidney outcomes. In elderly patients, the target needs to be individualized, so based on their frailty assessment and comorbidities, there is no need to rush and lower down their BP to 120 or 130. So sometimes these patients develop renal ischemia and acute kidney injury because of that. So the first line agents which we can use.
Kindly sum up as soon as possible.
Okay. So first line agents which can be used in such cases are the RAS inhibitors, CCBs or thiazides guidelines. That about diet, the modified DASH and maintenance diets are the mainstay of this treatment because it reduces the systolic and diastolic BP and CKD through improved endothelial function. The Japanese guidelines
कैलोरी डाइट ले रहे हैं बट हम कौन सी लो कैलोरी डाइट ले रहे हैं दैट एक्चुअली ऑल्सो मैटर्स लेकिन कार्बोहाइड्रेट लो कार्बोहाइड्रेट डाइट के साथ ऐसा नहीं है लो कार्बोहाइड्रेट डाइट डायरेक्टली जस्ट इंटरफियर्स विद द जैसे स्वामी सर ने बोला था लेप्टिन रेजिस्टेंस एंड इंसुलिन रेजिस्टेंस ऑल्सो अब डेटा प्रूफ करने के लिए है हमारे पास यस सबसे बेटर डेटा है वेटा हेल्थ दिस इज अ 2-year type 2 diabetes outcomes 60% of the participants reduce or eliminated diabetes medications excluding metformin at 2 years जिसने भी low carb डाइट ली है mean HbA1c fell from 7.6 to 6.3% in 1 year reversal actually achieved in over half of the completers at 1 year and comparator arm receiving usual care showed no significant change in HbA1c or medication use अब प्रॉमिस बताएगा डायरेक्ट ट्रायल के बारे में बट डायरेक्ट ट्रायल में भी कैवियट्स थे ही विल सर्टेनली टेल अबाउट डायरेक्ट ट्रायल अब क्या होता है व्हाई दिस एक्चुअली व्हाई डायरेक्ट ट्रायल एक्चुअली स्टिल हैव टॉपिक्स टू डिबेट बिकॉज बाय 2 years जो भी हमने देखा था कि यस डायबिटीज रिवर्सल हो रही है और रेमिशन हो रही है दैट रेमिशन फेल टू 36% एज वेट वाज रीगेन द ड्यूरेबिलिटी प्रॉब्लम रीअपियर्स वंस द एक्सट्रीम रेस्ट्रिक्शन फेज एंड्स और अब लिक्विड मील रिप्लेसमेंट प्रोटोकॉल अब हम कब तक चलाएंगे भैया लो कैलोरी डाइट में हम लेस देन 900 किलो कैलोरीज पर डे इज नॉट कंपेरेबल इन सस्टेनेबिलिटी टू एवरीडे लो कैलोरी काउंसलिंग हम रोज ऐसा नहीं मेंटेन कर सकते हैं और हमारे पास ये डेटास भी हैं यस एंड इवन डायरेक्ट्स जो ऑथर्स हैं इवन डायरेक्ट ट्रायल ऑथर्स एट्रीब्यूट बेनिफिट टू द रिजल्टिंग वेट लॉस अल्टीमेटली हमारा टारगेट क्या है भैया वेट लॉस करना कैसे भी करना है हमें वेट लॉस करना है तो attribute benefits of the resulting weight loss the very magnitude low carbohydrate diets achieve without formal calorie counting हमें कटोरी दाल 100 ग्राम 50 ग्राम ये काउंट करने की जरूरत नहीं है लो कार्बोहाइड्रेट डाइट ले लो सिंपल आपको क्या करना है एंड दैट हैज बीन लो कार्बोहाइड्रेट डाइट हैज बीन सस्टेन्ड बाय द पेशेंट्स फॉर ऑलमोस्ट मोर देन 1.5 and 2 years यस हम हेड टू हेड ट्रायल्स भी हमारे पास है या डाइट फिट्स ट्रायल है वेटर ट्रायल है मेटा एनालिसिस है एंड ऑल दीज ट्रायल्स हैव शोन दैट लो कार्बोहाइड्रेट प्रोड्यूस सिग्निफिकेंटली ग्रेटर वेट लॉस अल्टीमेटली हमको तो वेट लॉस ही चाहिए ना किसी भी चीज में हो बाय वेट लॉस ओबेसिटी इज द मेन टारगेट तो अल्टीमेटली low carbohydrate diet produce significantly greater weight loss and greater LDL triglyceride improvement despite no calorie counting. Most importantly, no calorie counting. अगर हम HbA1c रिडक्शन भी देखें लो कार्बोहाइड्रेट वर्सेस लो कैलोरी लुक एट दैट हम अगर देखते ऑलमोस्ट यस लो कैलोरी डाइट में HbA1c रिडक्शन वाज मोर बट अगेन दैट वाज नॉट सस्टेन्ड बट इन लो कार्बोहाइड्रेट डाइट द मीन HbA1c रिडक्शन वाज ऑलमोस्ट सस्टेन्ड अप टू 1.5 and 2 years. एक और चीज है लो कार्बोहाइड्रेट में वन वेट आई टेक मेडिकेशन डिप्रिस्क्राइबिंग इवन इन वेटा ट्रायल 94% ऑफ द इंसुलिन यूजर्स रिड्यूस और एलिमिनेटेड इंसुलिन एट 2 years and mean insulin dose fell by more than 80%. Multiple carb restriction trials report sulfonylurea discontinuation rates far exceeding those seen with low calorie or low fat comparators. And reduced carbohydrate load lowers the substrate driving postprandial glucose excursions, directly reducing the pharmacology correction needed. 2 minutes I'll take, है ना? अगर हम ट्राइग्लिसराइड की बात करें लो कार्बोहाइड्रेट डाइट इंप्रूव ट्राइग्लिसराइड इंप्रूव्ड एचडीएल इंप्रूव्ड एलडीएल एंड इंप्रूव्ड ट्राइग्लिसराइड एचडीएल रेशियो मोर इंपॉर्टेंटली meta-analysis have also shown that again when calorie intake is not controlled in both arms low carbohydrate diets consistently produce greater short and medium term weight loss than low fat diets across multiple systematic reviews. Yes, protein ज़्यादा satiety बढ़ जाती है reduce insulin driven shortage ghrelin suppression हो जाता है and fewer hyperproctable trigger foods with low carbohydrate diets. Improve hepatic fat and NAFLD 30% of the patient relative reduction in intrahepatic triglyceride content reported within days to weeks of carbohydrate restriction जो कैलोरी के साथ नहीं मिलता है. So that is the reason carbohydrate restrictions targets the liver directly as compared to the low calorie diet. Blood pressure, fasting, insulin, inflammatory markers, waist circumference, everything improved with low calorie diet. Sustainably, that is more important, sustainably. And जल्दी से Type 2 diabetes is the clearest win. Yes, type 2 diabetes as its core, a disease of carbohydrate intolerance, more importantly, impaired ability to dispose of glucose load. And the remission data is not a marginal signal. more than 50% of the Veta completers achieved HbA1c of less than 6.5 of glucose-lowering drugs, and every major diabetes organization, be it ADA, be it ASD or ACE, now explicitly recognize low carbohydrate eating patterns as an evidence-based option for glycemic management, and this is no longer a fringe position. To summarize quickly, a calorie is not metabolic inert in insulin-resistant patients. Carbohydrate load independently drives the hyperinsulinemia. Head-to-head and cohort evidences consistently favor carbohydrate restrictions on glycemic control, lipids, and weight loss. And medication prescribing, of course, up to 94% of the insulin users reduced or stopped insulin. And to HDL, long-term data caveats are real but manageable with monitoring. And for metabolic diseases specifically, restricting the substrate the disease can't handle is a more direct, more sustainable, and better evidence strategies than asking patients to count calories indefinitely, lifelong. Thank you.
हेलो सर
सर मेरे ख्याल से दोनों का डिबेट हो जाए उसके बाद फिर क्वेश्चन ले लेंगे. सो थैंक यू अभिषेक. बेसिकली अभिषेक हैज sort of was a proponent for low carbohydrate diet, but we should make a clear distinction that low carbohydrate is less than 130 gram and keto diet is less than 50 grams of carbohydrate per day. So these two are different. So keto and low carbohydrate are different. And before, I'm inviting Dr. Promise Jain, who is a physician and intensivist from Bhopal with a keen interest in endocrinology and cardiometabolic disease, to speak on the low calorie diet.
Thank you, sir. First of all, thanks Adit and the whole organizing team. And when I come here, I noticed some beautiful places in Chambal division. And definitely Chambal is famous for the Dakus, but who is it? Pan Singh Tomar is a Daku, but one of the favorite hero. कि अच्छा काम किया इसने. सेम मेरे साथ भी है, मैं भी अच्छा ही काम करूँगा, थोड़ा सा अलग हटके. And definitely Dr. Abhishek told that gajak should not be eat. And in Morena and Chambal region, I think no one left with the gajak. So everybody should eat the gajak. How much we will discuss in later. So thank you all. So, and I will give brief on the low calorie diet. So basically low calorie diet is that if consume calories in amount of less than 1500 calories. That is the low calorie diet. So my the question is that for the Abhishek, is carbohydrate restriction is the key to diabetes control, and I favor is calorie restriction is the real driver of the metabolic improvement. So it is not for the diabetes only, it is for the metabolic improvement also. This comes from the twin cycle hypothesis by Rose Taylor in 2008, and he said that if you are consuming the excess of calories, that will lead to the type 2 diabetes with the various disruptions in the metabolic pathway as shown in the picture. And on the other side, if we reduce the calories in diet, so we improve the various metabolic disruption, after all remission or remission. We have, Dr. Abhishek told us two or three trials like Veta trials. Veta trial पर $1.2 billion का पेनल्टी हुई है 2025 में. Why? So this is understandable. So counterpoint study, counterbalance study, direct trial, all these trials shows the benefit of the low calorie diet in term of the, suppose counterpoint study says calories reverse liver insulin resistance. Low carbohydrate didn't reduce the insulin resistance. It will maintain the weight loss and maintain the remission. Weight loss can reverse type 2 diabetes in direct trial, which Abhishek tell the various caveat in the direct trial, but the ultimate result is that weight loss. Diadem trial, treat early, remit early. Even type 2 diabetes who are the lean can remit by reducing ectopic fat. Obesity is the different. Ectopic fat in that various like fatty liver. If we reduce the fatty liver, we increase the insulin sensitivity. And if I look at trial by in the USA, lifestyle improves long-term metabolic health. So the low-calorie diet is a part of the lifestyle improvement. But no low-carb trial has demonstrated remission rate compared to these when major weight loss is achieved. So with all these trials, calorie restriction and that resulting weight loss as the principal driver of remission, while low carbohydrate diets are one possible strategy to help some individual achieve that energy deficit. So low carbohydrate diet, why better in the short term? It is better in the short term, but after 12 months, the initial benefit of the low carbohydrate diet diminishes over the period of time. And finally, some meta-analysis and RCT compared, and they showed definite benefit of the energy deficit, not carbohydrate restriction. And these are the dominant mechanism in the improvement of the metabolic health. Various guidelines from ADA, ESDA, they all major guidelines emphasize sustained calorie deficit over a specific macronutrient ratio, that is the carbohydrate. So definitely, I think I convince you the low carbohydrate diet is better with the strong evidence for the remission. It reduces the liver and pancreatic fat, restore beta cell function, it is flexible and sustainable, and it improves multiple cardiometabolic risk factors. And there is some potential concern in the low carbohydrate. It may lead to the constipation, reduce dietary fiber, keto flu if you are less than 50 gram of carbohydrate. There is the micronutrient deficiency. It increases the LDL actually, and a difficulty in CKD or pregnancy. The Veta trial doesn't imply in the pregnancy patient and insulin pump patient. And risk of the euglycemic ketoacidosis is SG12, which is the nowadays the main treatment part. So with this, I conclude that calories matter more than carbohydrates. Low calorie diet improve the weight, ectopic fat reduction, beta cell recovery, and diabetes remission. You should eat with the smart calories and with the common sense. This book recently published by Dr. Anup Mishra, and here Dr. Navneet Agrawal sir and Parimal Swami, who are working on the aging and longevity. Dr. Parimal sir already mentioned this type of the smart calories in his book also. So I think we should consume the gazak with smartly. ट्रेडिशन का स्वाद और हेल्थ का ध्यान हमेशा ध्यान रखना चाहिए, और दोनों का संतुलन बहुत जरूरी है. So enjoy the gajak and count the calories. Thank you very much.
Both these speakers have explained their position very well, and I think the session is open for the question and answer. I am not asking for the show of hand, because both of them said the same thing, which I will say at the end. So both have said the same thing, and both are right. Nobody is wrong. So the session is open for the question.
Awesome. Sir, what is the role of protein powder, particularly whey protein, in weight reduction, and how much it is safe?
Sir, it is safe if you are consuming the branded, like those protein powder doesn't have the steroid and other things, but the protein consumption is very important. आप यदि वेट लूज करना चाहते हैं और प्रोटीन पाउडर नहीं लेना चाहता, that is the one important thing. So you should consume the protein so smartly. डॉक्टर नवनीत सर ने मुझे एक बार बताया था कि आजकल जो डाइट है बेसिकली हम जो खाते हैं वो चेंज क्यों हो रही है, क्योंकि उनकी खुद की जेनेटिक्स चेंज हो गई है. जिस चीज़ के लिए हम जो चीज़ खा रहे हैं वो उसमें वो चीज़ें अवेलेबल नहीं है. तो ऐसे ही जैसे आप रोटी खाते, तो रोटी खाना कोई ख़राब है क्या? तो आजकल तो सोशल मीडिया पे ये है कि रोटी खाना बहुत ही मतलब यदि आजकल हायर सोसाइटी में देख लो, यदि आप रोटी किसी को बता दो कि मैं चपाती खाता हूँ, मैं मल्टीग्रेन आटा यूज़ नहीं कर रहा हूँ, तो वो पता नहीं कैसे देखते हैं। तो मैं ये कहता हूँ उसमें कि यदि आप सर 2 से 3 ग्राम प्रोटीन एक रोटी में होता है, यदि आप इंडिया में से रोटी हटा देंगे तो प्रोटीन नहीं मिलेगा। तो रोटी को यदि आप इम्प्रूव कर देते हैं, यदि आप उसमें बेसन मिला लेते हैं 50%, तो वो 10 ग्राम प्रोटीन आपको दिन भर में दे सकता है। तो ये है स्मार्ट। तो आपको अलग से प्रोटीन पाउडर लेने के, पर आपका क्वेश्चन है कि प्रोटीन पाउडर लेना चाहिए कि नहीं। यदि प्रोटीन पाउडर अच्छा है, वे प्रोटीन है, तो आप ले सकते हैं। आजकल ईस्ट प्रोटीन भी आने लगा, पर ईस्ट प्रोटीन में थोड़ा से प्रॉब्लम, एक तो कॉस्टली है कंपेयर टू द वे प्रोटीन, दूसरा उससे जीआई प्रॉब्लम्स थोड़ी ज़्यादा हो, ऐसा मेरे को देखने में, मेरा कोई डॉक्यूमेंटेड नहीं है, पर जो जिम वगैरह जाते हैं वो लोग कंप्लेंट करते हैं कि ईस्ट प्रोटीन थोड़ा सा प्रॉब्लमेटिक है। एनी कमेंट?
गुड।
सर जैसे मैंने भी बताया ना, रोटी का जीआई इंडेक्स जो है वो 70 होता है। यदि आप उसमें बेसन मिला लेते हैं तो वो हाफ हो जाता है। क्या सर? ब्रेड तो सर खानी नहीं चाहिए ना, यदि वैसे देखा जाए तो।
ब्रेड का सर बहुत, वाइट ब्रेड का बहुत ज़्यादा होता है, सबसे ज़्यादा होता है
सर। एक्चुअली सर ब्रेड बनाने का तरीके पे बहुत इम्पोर्टेंट होता है सर। ब्रेड को एक्चुअली में 2 बार गर्म किया जाता है, और वो 90% चांस है कि उसमें मैदा होगा ही होगा, तो उसका ग्लाइसेमिक इंडेक्स ऑटोमेटिकली बढ़ जाता है।
Sir, one more question. Sir, in Maharashtra, there is a regime followed called Dr. Jagannath Dikshit diet for weight reduction and diabetes. Any comments and takeaway?
Who?
Dr. Jagannath Dikshit diet.
वो है सर, वो तो आप ऑनलाइन।
Dikshit diet is basically a very low calorie diet, and it contains mainly of the vegetables and fruits, as far as I know. They reduce the amount of grains and cereals. But like I wanted to say at the end, whatever you do, you low carb diet, low calorie diet, they basically modulate the amount of calories also. So unless you reduce the amount of calorie, you cannot lose weight. Now there are various means. You make the diet palatable, and the patient is having satiety. With a low calorie diet, it is the best diet for that particular patient. You are eating a very, very ideal diet, but that patient is not getting satiety. After few months or few weeks, he will leave that diet. So that is one of the way. And then again, you join a group, you are motivated by your colleagues or the fellow patient who are taking the same diet. Everybody is posting their result in a same platform, like मेरा HbA1c इतना हो गया, मेरा weight 4 kg कम हो गया. So that momentum and sort of a motivation keeps you forward. But everything comes to an end in these things, and you have to have the intrinsic motivation to become more healthy. Once you have that feeling in your, or that emotion in your brain, only then you can follow a particular type of healthy diet. So
क्या सर? सर नॉर्मल पर्सन के लिए जो डाइट रिकमेंडेड है वो सर 50% ऑफ कार्बोहाइड्रेट आज के समय में होना चाहिए, बाकी का जो 50% है प्रोटीन एंड फैट से होना चाहिए। तो 20-25% प्रोटीन एंड 25% ऑफ फैट होना चाहिए, एंड इट शुड बी डिवाइडेड इन एटलीस्ट 3 मेजर मील्स।
Dr. Promise, I would like to have one comment. See, what you said is right. In fact, what Abhishek says is also right. Because we Indians consume lot of carbohydrate. So we definitely need some reduction in carbohydrate. And we also need low caloric diet. That is also true. It's not about debate. But what I really want to emphasize is that our lifestyle as in India has changed in last 5 decades significantly. With the evolution of the green revolution, making the grains in plenty, access to the Indian needs. After that, in 1992, wherein the International Trade Summit, means Gate Samjhauta, which allowed the entry of high caloric food to the Indian subcontinent. And third thing, the digitalization happening in India, wherein you can get all kind of food at a click by Swiggy or Zomato, which has reduced the mobilization. So perhaps the type of change in the lifestyle is probably not at pace with the dietary modifications. So no diet was bad. In fact, high carbohydrate diet was not bad 50 years back. It didn't cause diabetes that time. But what has changed? We have changed. Our lifestyle has changed. And probably we failed to educate us lot. हम लोग आपस में पब्लिक को और खुद को एजुकेट करने में पीछे रह गए.
That is the biggest problem
That is the
actually.
biggest thing. Navneet sir will have an expert comment on this.
Thank you. So basically, like, there is no fight in carb versus calories. The single dictum is it should be a mindful eating. Because I've been a part of the multiple companies, like you said, Verta Health, Abhishek quoted. I was the medical director for Verta Health in India. Somewhere back, we started Verta in almost 12, 14 years back. Where this was a US company. They have the highest funding in the digital attack that time. And this was the company who initiated or who designed or coined the term of reversal, diabetes reversal, somewhere 15 years back. So 14, we started in India. And they were doing with the keto diet. But the keto, when it comes to the keto, as Dr. Swami said, it is the carbs less than 50 grams. So why keto or why low carb diet? Because in blood-brain barrier doesn't crosses, because like brain survives only on glucose. It cannot metabolize ketones. Our cells need only glucose, and brain is absolutely dependent on glucose. But after 48 hours of restriction of glucose, this blood-brain barrier allows the ketones to enter into the brain. But that is only when you have a restriction of that level. Then your brain, because like ketones are superfuel. So when we used to do keto, but that is not sustainable, particularly for the vegetarian people. So diet has already been a differential, it is a topic of debate. Now when I started working with the anti-aging and longevity and all that, so nowadays the concept is of Mediterranean diet. So what is this Mediterranean diet? Mediterranean diet is the basically diet which is being followed by the countries which are around the Mediterranean. And these are called blue zones. And these are the 5 blue zones where the average lifespan of a person is more than 100 years. Around 100 years, they have the highest number of centenarians. That means people living around 100. And that too without any disease. They are healthy. It's not lifespan, it is health span. And then they research that what is in their diet. And now we have started this Mediterranean diet which is being followed by across the globe, that this was the diet which they were following. So, कुछ भी rocket science नहीं है किसी भी diet में. The problem is we are more refined, we are more of the calories or the carbs, whatever say. I always talk everywhere, Indians या दुनिया में कहीं पे भी ना हम घड़ी से खाते हैं, भूख से नहीं खाते. 9 बज गए, नाश्ता करके चले जाओ, ऑफिस जाना है, लेट हो रहा है, भूख लगी नहीं लगी, नाश्ता कर लिया, 1 बज गया, लंच हो गया, घंटी बज गई, लंच करना ही करना है, भूख लगी नहीं लगी करी. So we eat by watch rather than hunger. That's why we are eating more of carbs, more of calories. Second thing is, it's difficult, as Dr. Narmada was saying, increasing the awareness. हमारे में जितना हेल्दी है, जितना मोटा है, वो ज़्यादा हेल्दी है. यदि बच्चा दुबला पतला है तो पूरा खानदान है, मोहल्ले वाले टोकेंगे, बच्चों खिलाते नहीं, कैसा सूख रहा है. So meaning the obesity was considered as a healthy, now it is changing the perception of disease. So diet has always been controversial, but yes, ultimately the major, as Sir was asking, what is the best diet for a normal person? More of a rough and raw vegetable. It should be more of the like if you can incorporate the seeds, nuts, raw foods, that will help a lot.
True, sir. So I completely agree with sir. The point is, मैं हिंदी में बोलता हूँ, अंग्रेज लोग हमको नहीं सिखा सकते कि हमको क्या खाना है. Our traditional Indian food was not bad. It was always good. It will remain good. It needs some scientific modification. It needs some local research, as Swami sir, Agrawal sir is doing. And I request all of you to do the same. We need some local solutions suitable for Indian patients. That's the very basic of the today's educational program. Thank you.
Thank you, Dr. Namrata. And to sum up, the data says that the calories are important for the direction of weight loss. But the amount of carbohydrate is important for the outcome of immediate metabolic outcome. So you reduce the calorie, you will lose weight, you will going into the phase of reversal or remission of diabetes. You reduce the amount of carbohydrate, you will be getting immediate benefit for HbA1c and some lipid profile value. So both are important. And to sum up, for Indians, we need a reduced calorie, moderately low carbohydrate, high protein, high fiber diet. So thank you very much. Sir, I think because of the time constraint, we will be discussing it later. Sure.
But sir, intermittent fasting has no proven data, but it is beneficial.
Thank you so much, sir. I would like to request Dr. Parimal Swami, sir, speakers from our last session, and Dr. K.K. Gupta, sir, Shivat, sir, and Yogendra, sir, to please proceed for the felicitation. Now, the next session is on gestational diabetes mellitus. Pregnancy is a unique metabolic stress test that sometimes and somewhere diabetes makes its first appearance during its critical journey. GDM, that is gestational diabetes mellitus, is one of the most important metabolic challenges encountered during the pregnancy, where timely diagnosis and optimal glycemic control can significantly improve the outcomes for the mother and the baby. To guide us through this clinically relevant topic, it is my privilege to invite our distinguished speaker, Dr. Navneet Agarwal, sir, to share his expertise and insights on GDM. May I request Dr. Navneet, sir, to kindly take the podium and to enlighten us with the presentation. I would also like to invite Dr. Sudha Maheshwari ma'am, Dr. Vinita Singhal ma'am, Dr. Neeta Kushwaha ma'am, and Dr. APS Yadav, sir, for the chairperson status. So please.
Slide pointer नहीं है? ये चलता है? वो नहीं है? चलिए नहीं ये नहीं वो चाहिए लेजर चाहिए लेजर है नहीं है इसका लेजर तो नहीं चल रहा चल तो रहा है हाँ ये नहीं चल रहा एनीवे हो तो ठीक है चलो नहीं सो थैंक्स आदित्य फॉर द नाइस वर्ड आवाज आ रही है हाँ entire organizing team of Chambal Medicine Update and thank you very much for inviting me to have a discussion on not only restricted to GDM but I'll be covering the entire pregnancy with diabetes because like the diabetes or the hyperglycemia or the glucose intolerance in the pregnancy, it is the most common metabolic abnormality which we come across when we talk of the pregnancy, but we have a mixed audience, so like it's not restricted to only the gynecologists or the physicians, so like whatever diabetes is a disease, when any practice you are doing, you come across day in day out of the diabetes, and so I'll be discussing that with the some help of some hypothetical cases that how to manage whatever the options, because like we can see diabetes in pregnancy can be a pre-existing type 1, pre-existing type 2, or even it's a gestational. So we can come across any sort of patients. So we'll take example of some patient. This is a patient 34-year-old with type 2 diabetes, presents for follow-up. She has been uncontrolled on triple drug. Uncontrolled on triple drug and she wants to have a baby. So like she's asking like what should I do? So what would you advise? क्या advise करेंगे इसको? And क्या sorry? So good control and how to change the medication. Same another patient 28-year-old type 1 with the like came for the pre-conception counseling, and what relevant history would you like to ask? And what examination and investigation, like the pre-existing type 2, type 2 and type 1. So the story starts from before planning the pregnancy, and here comes the role of every one of us. Whosoever, whatever the specialty you are practicing, any lady who's coming to us and planning for pregnancy, the counseling for the pregnancy starts from that time only. So like educate and obtain the maximum cooperation from the both the parents. And मैंने last में और लिखा in-laws. जैसे ही पेशेंट को डायबिटीज पता लगती है सारी सासों को टेंशन हो जाती है, अब क्या होगा, वो लड्डू तो खिला ही नहीं पाएंगे, तो बच्चे को तो कुछ नहीं हो जाएगा, तो नारियल दे सकते कि नहीं दे सकते, ये दे सकते हैं. तो लाइक पूरे घर में एक वो अजीब सा माहौल हो जाता है. सर लाइक इन-लॉज में इन सब में डायबिटीज पता लग जाए, जस्ट लाइक इवन द GDM और एनी डिसीज. So you need a proper education and counseling of all the family, entire family, obtain the maximum like good control, whatever. Possibly before like before planning the pregnancy, if the A1C can be less than 6.5, APG less than 100, 2 hours, PPG less than 140, then definitely we can prevent the congenital malformation. So we should emphasize the need for the strict diabetes control, check for thyroid functions, antibodies if required, check for the immune status of the rubella, I am sure the all calculators are doing, and we should counsel that it is a multidisciplinary approach, not only the single specialty like obstetrician, gynecologist, physician, everyone is required, and we should explain the risk of congenital anomalies, perinatal mortality, diabetic complications, because like in pregnancy there may be flare up of the nephropathy, obstetric complications, increased risk of diabetes, and what a pregnancy with diabetes बार बार चेक करना है, 3 बार इंसुलिन लगाना है. आप सोचो एक प्रेग्नेंट लेडी को 9 महीने आप बोल रहे हो कि 4 बार शुगर चेक करनी है, 3 बार 4 बार इंसुलिन लगाना, मतलब रोज के 6 प्रेग. It's very difficult to convince a patient and the family, and it's not only just a prick, it's financial burden. आप सोचो जो गांव की लेडी जिसके पास अपने कभी किसी गांव में ग्लूकोमीटर नहीं है, अब आप उससे कह रहे हो ग्लूकोमीटर खरीद सिर्फ 9 महीने के लिए, फिर 4 बार प्रिक टेस्ट कर, एक स्टेप 10 रुपए की है, तो फाइनेंशियल बर्डन. सो इट्स अ ट्रॉमा टू द फैमिली. आप यू टू एक्सप्लेन इट, एंड देन अप्रोप्रिएट डाइट एंड लाइफस्टाइल, फिर फोलिक एसिड सप्लीमेंटेशन वगैरह तो आप देते ही हैं. So what is the preconception care? Just to summarize, achievement of optimal glycemic control, A1C less than 6.5, because आपके पास आए दिन पेशेंट आते होंगे जो कि मैडम हो गई हमें नहीं पता था, अब H1C आपने कराया 11 है. अब उसका अगला सवाल होता है मैडम कंटिन्यू करें नहीं करें, नहीं मैडम ने सर के पास भेज दिया, सर ने मैडम के पास भेज दिया, दोनों की फुटबॉल बनी हुई है, क्यों डिसाइड कौन करे? पेशेंट चाहता आप डिसाइड करो. अरे हम कौन डिसाइड करने वाले? अल्टीमेटली डिसाइड तो फैमिली को करना है, बिकॉज लाइक हम क्यों हत्या मोल लें? भाई आपको डिसाइड करना है वेदर टू कंटिन्यू और. रोज आते हैं हमारे पास एक आधे ऐसा पेशेंट जो कहता था आप बता दो हम तो आपकी मान लेंगे. अरे मैं कौन हूं? यू हैव टू डिसाइड. मैं सिर्फ साइंस बता सकता हूं. सो लाइक द साइंस सेज दैट द A1C एट बिफोर द कंसेप्शन और पेरी कंसेप्शन मोर देन 9.3, chances of congenital malformations are almost more than 90%. So the A1C more than 9.3 मैं साइंस से कह सकता हूं कि नहीं करनी चाहिए. बाकी तो ईश्वराधीन है, सब कोई नहीं जानता क्या होगा कैसे होगा. बट इफ यू विश टू कंटिन्यू A1C 9, क्योंकि वो पेशेंट आता कहता था अब कंट्रोल कर लेंगे ना, कंट्रोल करने से होगा. सो विल डिस्कस इन दैट स्लाइड. If patient is on OAD, switch over to the insulin. Patient antihypertensive है तो stop the ACE inhibitors, ARBs, shift to the labetalol and all that. Type 1 है तो dilated retinal examination. Diabetic retinopathy नहीं है because like that can flare up. Estimation of renal function because like कुछ nephropathy और जो kidney functions हैं they may flare up, they may progress during pregnancy, and statins to be stopped. बहुत सारे पेशेंट आते साहब मुझे हाइपरलिपिडेमिया है, स्टैटिन शुरू किया था, प्रेगनेंसी में क्या करूं? दे हैव टू बी स्टॉप्ड, वी कांट कंटिन्यू दैट. सो इट हैज टू बी एक्सप्लेन्ड प्री कंसेप्शन. अब पेशेंट आ गई आपके पास फर्स्ट एंटीनेटल विजिट में, 28 साल की है, 10 वीक, देन BMI 29 है, अभी 10 वीक में आया. टेस्ट करेंगे क्या डायबिटीज के लिए? टेस्ट करेंगे. Will not wait for 24-28 weeks because like now it is being recommended that it should be a universal screening. So पहले जो था कि like पहले 24-28 weeks में करते थे, but now it is in India, it is a universal screening. We'll screen everyone. ठीक है साहब, कर लिया स्क्रीन आपने बोला तो जैसा हमने 75 ग्राम ग्लूकोज पे दे दिया, फास्टिंग 128 आ गई, PPG 204 है, A1C 7.9 है. क्या डायग्नोसिस है? 10 हफ्ते हुए अभी. सो प्री एग्जिस्टिंग टाइप 2 डायबिटीज है, नॉट दी GDM. पुरानी डेफिनेशन में था कि कभी भी डायग्नोज हो प्रेगनेंसी में तो यू लेबर इट एज अ GDM, बट इट इज प्री एग्जिस्टिंग. व्हाई वी आर कंसर्न अबाउट इट? बिकॉज लाइक इफ यू देखेंगे दिस इज द सेंसिटिव पीरियड, जो मैजेंटा कलर में, दिस इज द सेंसिटिव पीरियड. पेशेंट हमारे पास आती है कब? जब उसको फर्स्ट पीरियड मिस हो जाता है, तो ऑलमोस्ट 4 से 6 हफ्ते हो गए. अब पेशेंट के बोलता है डायबिटीज पता लगी, H1C 9 आ गया है, बोले सर अब आज इलाज शुरू कर दो, कंट्रोल कर देंगे, आगे सब ठीक हो जाएगा. आप सोचो 6 से 8 हफ्ते 9 हफ्ते में तो इतने सारे ऑर्गन्स बन चुके. सो इट्स ऑलमोस्ट हाफ ऑफ द पार्ट इज डन. अब ये कंजेनिटल माल्फॉर्मेशन कब होंगे? जब डिलीवरी होगी और कोई टेस्ट करा लो, किसी टेस्ट से कुछ पता लगना, बेसिकली आप कलर डॉपलर कुछ भी करोगे 16 वीक्स के बाद, तब तक तो ऑलमोस्ट सब आप उसके बाद फिर आप टर्मिनेशन भी बहुत मुश्किल है. सो यू हैव टू अंडरस्टैंड, यू हैव टू एक्सप्लेन दैट कि भैया जब प्री कंसेप्शन तेरा यदि H1C इतना था और इतने सारे ऑर्गन्स ऑलरेडी बन चुके हैं और खराब हो चुके हैं, सो प्री एग्जिस्टिंग टाइप 1, प्री एग्जिस्टिंग टाइप 2 can damage, and it is morely responsible for congenital malformation. We don't see congenital malformation in GDM because it develops after 24 weeks. So it is to be very clearly like कौन से वीक में कितना hyperglycemia है उसके हिसाब से कितने complications होंगे. So that is done. So we can see this type 1, type 2, so like 20% are diabetes in pregnancy, almost 80% are GDM क्योंकि GDM का prevalence और prognosis बढ़ रहा है. So Asian type 30-year-old 10 weeks हमने GTT किया, फास्टिंग 98, PPG 138, A1C 5.6. अभी क्या करेंगे? कुछ नहीं, नॉर्मल है, कंटिन्यू प्रेगनेंसी कंटिन्यू करेंगे. फिर अब आगे क्या करेंगे? हाँ, फॉलो अप कब करेंगे? फिर हम 24 वीक्स पे करेंगे 75 ग्राम। 10 वीक्स पे नॉर्मल है तो ये नहीं मानना है कि अब इसको नहीं होगी, 24 वीक्स पे दोबारा करना है। और ये 24 वीक्स का नॉर्मल है तो अगेन इफ इट इज रिक्वायर्ड, आपको लगता है कि पॉलीहाइड्रोमनियोस है या कुछ भी है, तो आपको दोबारा से 30 वीक्स पे करना है। सो आपने दोबारा किया 24 वीक्स है, जो पेशेंट पहले नॉर्मल थी, अब वो 24 वीक्स पे उसका फास्टिंग 104 है, 1 आवर 181 है, 2 आवर 161 है। क्या है? GDM है एज पर IADPSG क्राइटेरिया। सो IADPSG क्राइटेरिया में 3 पैरामीटर्स होते हैं। हम पहले IADPSG देखते हैं, फास्टिंग more than 92, 1 hour more than 180 and 2 hours more than 153। पर इनको रटना है, दिमाग में लगाना, याद रखना बड़ा मुश्किल है, इसलिए वी फॉलो ओनली इंडियन गाइडलाइंस, दैट इज डिप्सी गाइडलाइंस। और उसमें क्या फास्टिंग चाहिए। अब पेशेंट आई है सबलगढ़ से, मैडम राठी के पास, कल कहाँ आएगी वो, दोबारा खाली पड़े, वो तो सवेरे पूड़ी और आलू खा के ही आई थी। अब कैसे फिर आप फंसे हुए, आप बोलो कल आ जाना, अब नहीं आ रहा अगले महीने, तो मैडम बोनी का टाइम चल रहा है। सो दैट्स वाई बिकॉज ऑफ ऑल दीज कंसर्न्स वी आर कंसर्न लाइक सिंगल टेस्ट irrespective of the meal, जिस समय आया जैसे आया, पेशेंट का जस्ट 75 ग्राम ऑफ द ग्लूकोज एंड वन टेस्ट दैट इज 2 hours, एंड इफ इट इज मोर देन 140 पेशेंट इज GDM। सो ये पेशेंट GDM हो गई। So it is a condition with onset or recognition first time during pregnancy which is not overt. So previous definition से हमने क्या, prevalence in India ranges from 4 to 21 and like they have an 11-fold increase risk of GDM as per to the like the Europeans and Caucasians, and about 30 to 50% of women with the GDM they'll progress to type 2 diabetes. So ये बड़ा concern है कि GDM is not only limited to this pregnancy, it is for the future, it is for the future of kid or unit and future of the mother also. Pathophysiology, we all know that is increased estrogen, progesterone. We are left with only 3 minutes. This is the pathophysiology. So like we should understand like जो hyperglycemia किस level पे होगा, किस time पे होगा, और वो क्या क्या changes करेगा। Like first trimester में तो congenital anomalies, second trimester में तो macrosomia and organomegaly, delivery के बाद है तो birth injury, neonate के time पे है तो उसको like बच्चे के neonatal complications, and childhood adult में जाके the risk of type 2 diabetes in the future. एंड नाउ सब पेशेंट 30 वीक्स पे आई है, फास्टिंग 90, 176, 154 है, क्या करेंगे 30 वीक्स पे। सो 90 फास्टिंग है, 1 hour 2 hour PPG 154 है। सो विल ट्रीट एंड रीअश्योर, बेसिकली सिंगल क्राइटेरिया में यस। सो लाइक इसी पेशेंट में 2 hours यदि देखें, पेशेंट का अपन ने फॉलोअप शुरू किया, फास्टिंग ठीक है, 1 hour 130 to 148 है, लंच के बाद 118, 136 है, डिनर के बाद 157 है, फीटल ग्रोथ अप्रोप्रिएट है, क्या करेंगे? सो वी हैव टू ट्रीट मेडिकल न्यूट्रिशन थेरेपी। सो लाइक मेडिकल न्यूट्रिशन थेरेपी, प्रेगनेंसी अप्रोप्रिएट फिजिकल एक्टिविटी, स्ट्रक्चर्ड ग्लूकोज मॉनिटरिंग, एजुकेशन एंड फॉलो अप, एंड वी शुड रीअसेस द पैटर्न। सो दिस इज द टारगेट। प्री मील शुड बी लेस देन 95, 1 hour शुड बी लेस देन 140 एंड 2 hours शुड बी लेस देन 120, बट नॉट अ सिंगल वैल्यू। क्या होता है 5 दिन में 7 दिन में, क्यों 90% लोगों के पास तो मीटर होते नहीं है, लैब से चेक कराते हैं 10 दिन में 15 दिन में। सो लाइक विद अ सिंगल वैल्यू, विद अ सिंगल टेस्ट ऑफ 10 days यू कांट सी कि क्या चल रहा है। सो आइडियली वी शुड डू, रिकमेंडेड तो बहुत सारा है, बट आइडियली 3 दिन 4 दिन हम प्रैक्टिकली पोजिशन को बोलते हैं, आज फास्टिंग कर ले, कल नाश्ते के बाद कर लेना, परसों लंच के बाद कर लेना, अगले 4-5 दिन में आपके पास बहुत सारा डेटा होता है, एंड देन यू कैन मॉडिफाई ऑन द बेसिस ऑफ दैट। सो लाइफस्टाइल थेरेपी, यस, न्यूट्रिशन, अभी बहुत सारी बहस हमने सुनी, कार्बोहाइड्रेट, कैलोरी, सो लाइक इंडिविजुअलाइज द कार्बोहाइड्रेट डिस्ट्रीब्यूशन, फूड क्वालिटी, मूवमेंट जो प्रेगनेंसी के हिसाब से सेफ है, वेट गेन होना ही होना है, 10 किलो तो आपको पता ही है प्रेगनेंसी में होना है, एंड सो प्रेगनेंसी इज नॉट द राइट टाइम टू लूज वेट। डोंट टारगेट के वेट लॉस करना है प्रेगनेंसी में, अब जो बढ़ना है, जो बढ़ना करना था, जो पहले करना था। एंड देन फाइनली द एजुकेशन इज इंपॉर्टेंट। अब आपने जैसे मान लीजिए किसी पैटर्न देखा, 7 days का हम देखें पैटर्न, सो बीच बीच में जा रही है, ये ऊपर वाली हम देख रहे हैं, ऊपर वाले ग्राफ में, सो इट इज गोइंग 150, 160, दैट मीन्स पेशेंट स्टिल नीड्स करेक्शन, इट इज नॉट बीइंग कंट्रोल विद द मेडिकेशन, द लाइफस्टाइल ओनली। सो लाइफस्टाइल नहीं है तो उसके बाद क्या करेंगे? लाइफस्टाइल के बाद what treatment we need? Metformin or insulin? Metformin or insulin is still a debate. Metformin, yes, it is being preferred. Oral है, patient लेने में तैयार है। मैं I'll skip those slides. It is a category B. It is controversial animal production study. अरे मेरे को माइक दे देना, मैं फटाफट करता हूँ। It is non-teratogenic, safe and IVF pregnancy. Metformin approved पुराने में, but ADA don't recommend. Metformin बहुत सारी ट्रायल्स में यूज हुई। So basically, it reduces the risk of preeclampsia, reduces the risk of LGA babies, no increased risk of congenital malformations, less pregnancy weight gain, reduced dose of insulin. But बहुत सारे पेशेंट मेटफॉर्मिन अकेले से कंट्रोल नहीं होते. This was being seen in the MIG-TOFU trials और बहुत सारे trials. So yes, insulin is the ideal answer, but patient don't prefer insulin. बट मेटफॉर्मिन से बहुत सारे पेशेंट कंट्रोल नहीं होते, अल्टीमेटली दे नीड इंसुलिन. इंसुलिन इज द ओनली एज पर रिकमेंडेड ट्रीटमेंट फॉर दी management of either GDM or pre-existing type 1 or pre-existing type 2. But insulin में it's not necessary that all patients require 4 times. Some patients require only at, because like the insulin resistance is higher at the breakfast. Some patients are comfortable with only a single prick. Even at the breakfast, even at the lunch, there are multiple permutation combination of insulin, 30-70, 50-50, regular, basal, whatever you can choose depending on the patient's का monitoring का status कैसा है, क्योंकि आप एक तरफ से like it's not a blinded treatment कि सबको एक जैसा चाहिए. So yes, you need to educate. And then finally, what are we trying to prevent? Yes, mother में हम diabetes prevention. I'll skip the slide because we are running short of time. So delivery planning, GDM alone is not an indication for cesarean. You just wait. GDM well controlled. There is no emergency. आपको लगता है obstetric parameters हैं जो compel कर रहे हैं for the cesarean or whatever like the intervention, you should go for it. But otherwise, GDM alone just presents, if it is well controlled, maybe pre-existing type 2 you don't need. एक और है, हमेशा steroids के बारे में बहुत सारे patients हो जाते हैं. Whether we could give steroids or not, if the patient is well controlled, yes, definitely give. Even if the patient is not controlled, you can give steroids. We'll titrate the dose. We'll modify the dose of insulin. But ultimately, the steroids are required for the lung maturity, and that is to be given. So this is the postpartum visit. After the delivery, yes, what we can do after the postpartum, once the patient is delivered, normally then we should use it as a prevention of diabetes for the future. So like we should go for again a 2 or 75 OGTT, and if the patient comes out to be diabetic, because like 30 to 50% patient they turn to be diabetic, they should be treated as a type 2 diabetes. The Crude trial where like WHO 25 adds a global management framework for emphasizing the hyperglycemic control. So just to take home, we should pre-pregnancy counseling, before pregnancy we should counsel them so that we can prevent all these complications in the pregnancy. We should screen for GDM, if not already diagnosed, we should diagnose. One consistent strategy, we can use a DIPSI guideline, one single step, treat, lifestyle, SMBG, pharmacotherapy, depending on the metformin, insulin, what patient requires. We should integrate the fetal growth, metal status and delivery planning depending on the hyperglycemic control, and postmortem definitely we should screen them so that we can prevent diabetes in future, because ultimately it's not the matter of just one life. I think we can take the message. हम सबने देखा हुआ ये ग्राफ like photograph. This is from महाभारत, जिसमें अभिमन्यु ने माँ के पेट में रह के चक्रव्यूह को तोड़ना सीखा था. So if we can provide a good metabolic milieu in the when up neonate or the fetus in utero, we can prevent कि वो आगे metabolic के चक्रव्यूह में ना फंसे. Thank you very much. Sorry for running because
Thank you so much, sir.
Topic is very vast, but
Thank you so much, sir.
sir.
That measures capillary blood
Sir.
sugar, है ना?
Sir.
That is more than 10%.
Sir, 15 milligram. Ji, sir.
If we send the sample to the lab,
Sir.
they tell the sample what after 4 or 5 hours, है ना? Taking the sample. So this report we should rely.
सर जितनी भी गाइडलाइंस और जितने भी पैरामीटर्स और जितनी भी गाइडलाइंस हमें रिकमेंडेड है, दैट इज वीनस प्लाज्मा. आपके वाले पॉइंट को थोड़ा और कॉम्प्लिकेट करते हैं, फिर डिस्कस करते हैं. सो वी डू 3 टाइप्स ऑफ मॉनिटरिंग: कैपिलरी ब्लड, वीनस प्लाज्मा, होल ब्लड, और फिर CGMS, इंटरस्टिशियल फ्लूइड. सबकी अलग अलग कहानी है. सो कैपिलरी ब्लड, बिकॉज लाइक इट इज बीन कैपिलरी, द ग्लूकोज हैज नॉट बीन स्टिल यूटिलाइज्ड बाय द सेल्स, एंड व्हेन वी टेक वीनस, the blood which is coming from these capillaries, glucose has been utilized by the cells. So it is not the problem of meter, it is the problem of physiology. कि ये नीचे आना ही आना है. कैपिलरी में अभी भी आर्टेरियल ब्लड है जिसमें ग्लूकोज है, सेल ने लिया नहीं है, और यहाँ आते ही वीनस में क्योंकि वो सेल ले चुकी है ग्लूकोज, सो देयर इज अ डिफरेंस ऑफ 10 to 15 मिलीग्राम पर डेसीलीटर. ये तो सिर्फ हमारी फिजियोलॉजी है. उसके बाद मीटर कौन सी कंपनी का है, कैसे स्टेप लगाई है, कितना ब्लड लगाया है, स्टेप से कितनी उंगली गीली की थी, कितना से स्प्रिट लगाया है, दैट ऑल्टर्स द इंटायर मिलियो. अब आपने 5 उंगली से की है, 5 भी अलग लगा सकती है. सो कैपिलरी ब्लड इज जस्ट फॉर मॉनिटरिंग एंड फॉलो अप, नॉट फॉर डायग्नोसिस. दैट इज वन. Ideally for diagnosis, if you are doing a GTT, it should be done with the venous plasma. So the cutoff of 140 is a venous plasma, not even the whole blood. अब जो आपका वाला पॉइंट था, ब्लड यूजुअली जो लैब वाले लेते हैं, दे टेक इन सोडियम फ्लोराइड. ठीक है, सोडियम फ्लोराइड में ग्लूकोज को आप ऐसे रख सकते हो, आप यदि सेंट्रीफ्यूज कर लो हाल की हाल, आपने पूरा रखा है जिसमें सेल्स भी हैं, तो डेफिनेटली वो जो आपका कंसर्न है वो लो वैल्यू दिखाएगा। यदि वो 4 से 8 घंटे रखा रहा है, वो कैलार सबलगढ़ से आ रहा है मुरैना तक, तो वाकई में उसमें कम हो जाएगा। यदि उसने सेंट्रीफ्यूज नहीं किया है, यदि सैंपल तुरंत लेने के बाद उसने उसको सेंट्रीफ्यूज किया है, तो वो उतना लो नहीं आएगी। यदि लेकिन जितना लंबे समय तक आप रखेंगे, शुगर्स लो आएगी। सो यू शुड बी वेरी कॉशियस कि किस मेथड से उसने कैसा टेस्ट किया है, बिकॉज कैपिलरी ब्लड ग्लूकोज आर जस्ट फॉर दी मॉनिटरिंग और वी कैन से असेसमेंट, बट नॉट फॉर द डायग्नोसिस। बट एनीवे इसमें 140 आ रही है, उसमें 155 आ रही है, तो इंटरवेंशन तो हम वैसे भी नहीं करने वाले हैं, डाइट ही समझाने वाले हैं। तो यदि हम अपने क्लिनिकली बात करें, हमको तो प्रैक्टिस भी करनी है, अपन थोड़ी बैठे रहेंगे भैया तेरी वीनस की रिपोर्ट आएगी तब हम तेरे को इलाज लिखेंगे, मजीद को तो आज जाना है अभी। तो आप उसको क्या समझाओगे, 140 है, 165 है, डाइट कंट्रोल कर, कार्बोहाइड्रेट कम करते, ये कम करते, वॉक बढ़ते, दैट इज नॉट गोइंग टू हार्म इवन वो नॉर्मल भी रही होती तो।
Most of patients are having glucometer at their home. If we send the sample to the lab, it shows normal, and they test at home, that shows high. Patient complain that there is one high.
सर आप उसको समझाओ कि मीटर में ज़्यादा आती है, उसको बता दो आप। सर उसका अच्छा तरीका, मेरे अपनी रूटीन प्रैक्टिस में मैं तो मरीज से बोलता हूँ, देखो मीटर को ना कैलिब्रेट करो। मैं एक CGMS की कंपनी चलाता हूँ जिसमें हम CGMS भी कैलिब्रेट कराते हैं, तो मैं तो मीटर कैलिब्रेट मरीज को समझाओ, अपने को तो अपना पीछा भी छुड़ाना है, प्रैक्टिस रोज करनी है, तो मरीज को बोलता हूँ देख अपना मीटर लेके जाना लैब पे और वहाँ जाके अपने मशीन से करना और लैब को देना, फास्टिंग पीपी दोनों। अब तेरा समझ में आ गया कि ये 20 का डिफरेंस खाली पेट में बताता है और 40 का डिफरेंस खाने के बाद बताता है, बस अब तेरा मीटर कैलिब्रेट होगा। अब जब भी लिखे ना 20 और 40 कम ही लिखना, तो इसमें 120 आ रही है तो 100 लिखना, क्यों वो लिखता है तो उसे सर में लगती है, और वो डायरी अपने को लाता है तो अपने में लगती है, तो मैं लिखवाता ही उसे हिसाब से हूँ, 100 की वो 120 की 100 लिख, 160 की 140 लिख, क्योंकि कैलिब्रेट कर लिया ना उसने अपना मीटर, बस उसका मीटर उसी से कैलिब्रेट करा दो लैब पे जाके। जस्ट एक मिनट
नवनीत सर।
सर इट इज सर ये सब किताबों में लिखी है, खुद ही करनी है।
नवनीत सर,
हाँ जी,
you had a very elaborate, excellent talk. So I just want to have one comments. ये गेस्टेशनल डायबिटीज़ का टॉपिक में बहुत सारा कन्फ्यूजन है, बहुत सारी गाइडलाइंस है, अलग अलग गाइडलाइंस हैं। मैं फिर से कहता हूँ, अंग्रेज लोग हिंदुस्तान की डायबिटीज़ का सॉल्यूशन नहीं दे सकते। फॉलो द डिप्सी गाइडलाइंस, फॉलो द डिप्सी गाइडलाइंस, योर आंसर विल बी सॉल्व ऑटोमेटिकली, योर ऑल क्वेश्चंस विल बी आंसर्ड। दे आर द सिंपलेस्ट गाइडलाइंस, they are most suitable for Indian subcontinent.
Definitely.
I hope sir would agree.
यस यस, सिंगल स्टेप 75 ग्राम ग्लूकोज, एक टेस्ट कर लिया, 140 के ऊपर है, डाइट और एक्सरसाइज समझानी है। हमारा बेसिकली अभी भी फिजिकल एक्टिविटी गांव में अभी भी लेडीज करती हैं, कोई प्रेगनेंसी में कोई रेस्ट तो करनी नहीं होती, until unless कोई और ऐसा कॉम्प्लिकेशन नहीं तो ऑब्स्टेटिक कॉम्प्लिकेशन।
And one more point sir, as far as our patient goes, उनका एजुकेशनल लेवल बहुत, मतलब डायबिटीज़ को लेके कम रहता है, अवेयरनेस कम रहती है। यहाँ CGM एक बहुत अच्छा टूल है, यदि आप उसको इनिशियली समझने के लिए, एजुकेट करने के लिए लगाते हो, नॉट फॉर मॉनिटरिंग, फॉर एजुकेशन पर्पस।
CGM का प्रॉब्लम ये है, एक मिनट हुआ है,
नॉट फॉर ऑल, फॉर सेलेक्ट पॉपुलेशन।
CGM का प्रॉब्लम ये है कि अगेन जो सरगा वाला शब्द था, ये कैपिलरी ब्लड, वीनस ब्लड और ये इंटरस्टिशियल फ्लूइड, ये समझना है। CGMS is in interstitial fluid, not capillary, not blood one. So yes, CGMS आप लगाओ, बट पेशेंट को पूरा एक्सप्लेन करके लगाओ, नहीं तो वो अगले दिन मेरा मयूर बात कर रहे थे, मयूर कहता था सर पहले मैं बहुत लगाता था, अब मैंने कम कर दिया है क्योंकि मरीज रोज सर पे खड़े होते हैं, वो इतना वेरिएशन आता है। सो आप एक्सप्लेन कर सको पेशेंट को, यस CGM इज अ गुड टूल टू अंडरस्टैंड कि मेरी इडली खाने के बाद कितनी, सांबर खाने के बाद, यस ट्रेंड। एंड नाउ देयर आर कंपनीज लाइक इवन वी आर डूइंग इट, दैट AI बेस्ड ट्रेंड। सपोज आपने एक CGMS लगाया, 15 दिन में समझ में आ गया रोटी खाने से, क्योंकि एवरी पर्सन हैज अ डिफरेंट रिस्पॉन्स टू द सेम कार्ब। सर की मेरी हो सकता है 2 रोटी से अलग जाती हो, मेरी नहीं जाती हो, सर की कम नहीं जाती हो। सो बेसिकली एवरी पेशेंट हैज अ डिफरेंट रिस्पॉन्स टू द सेम अमाउंट ऑफ कार्ब। CGMS कैन गिव यू एन इनसाइट दैट व्हाट इज द रिस्पॉन्स फॉर मी, and then on the AI based nudges you can make that I can guide my diet on the basis of that input of the data. So CGMS can be good for a pregnancy, yes it can be used, provided you should explain that it is interstitial fluid, not the capillary blood or venous blood, क्योंकि वो बहुत ज़्यादा hyper बहुत सारे CGMS में आते हैं, तो then they become panic, so that should not be done. Thank you very much, I think we are running short of time. It's a long discussion.
Thank you so much. Thank you so much, Navneet sir. I would like to ask Dr. Navneet sir and all chairpersons to please be there at the facilitation center. Our next presentation is on pregnancy-induced hypertension. Pregnancy is a journey filled with hopes and anticipation, but the conditions where the pregnancy-induced hypertension and preeclampsia can rapidly transform it to a challenging clinical situation, and that requires a timely recognition and decisive management. To guide us to this clinically relevant topic, it is my privilege to invite Professor Dr. Vrinda Joshi ma'am, an eminent gynecologist with extensive expertise in high-risk pregnancies and hypertensive disorders of pregnancy. The topic is pregnancy-induced hypertension, which will cover almost all the practical challenges. Ladies and gentlemen, please join me in welcoming Dr. Vrinda ma'am with a warm round of applause. I would like to invite Dr. Riturathi ma'am, Dr. Hema Singhal ma'am, Dr. Shweta Rajput ma'am, Dr. Chanchal Garg ma'am, and Dr. Mayuri Gupta ma'am to please be there as a chairperson. Thank you.
मैंने देखे ना इसमें क्या आपका कैमरे का भी बहुत सारा डाटा
इसमें हाइपरटेंशन इन प्रेगनेंसी है ना?
हाँ ये
नहीं ये फिर वो हाइपरटेंशन ये है ना फर्स्ट ईयर. Good morning, all the esteemed delegates and esteemed clinicians who are standing here as an august audience. And it's a proud privilege to me to be present here in the Medicine Update organized by IMA Morena. And I am so thankful to all of you for being allowed to present a topic which is very dear to my heart in both ways, because even today we are losing so many women and so many babies because of hypertension in pregnancy. And of course there is everyday change in the understanding of the problem that is there. So in 15 minutes whatever we will be able to share together, we will do. So classification of the hypertensive disorders, we all know chronic hypertension, and we are more interested in hypertension arising de novo at or after 20 weeks of pregnancy, which could be transient gestational hypertension, and preeclampsia, which may be de novo or superimposed on chronic hypertension. Yes. So today we will concentrate more on preeclampsia, because this is the condition which is taking the most of the toll. Even today we are losing patients day in and day out because of this condition. So International Society for the Study of Hypertension in Pregnancy, definition we know, the systolic blood pressure of more than 140 millimeter of mercury and diastolic blood pressure at 90 millimeter of mercury. But very importantly, it is not simply 140 or 90, it is the accompaniment by one or more of the following new onset conditions which are the most dangerous. So what are the conditions? There may be proteinuria, where there is more than 30 milligram per mole protein, creatinine ratio may be changed, 300 milligram per 24 hours or more than 2+ in the dipstick. And there is evidence of other maternal organ dysfunctions like acute kidney injury, where the creatinine is increased, liver involvement, where there are elevated liver enzymes, with or without right upper quadrant or epigastric pain. There may be neurological complications like eclampsia, altered mental status, blindness, even stroke, clonus, severe headache, persistent visual scotomata. All these are the corollaries of preeclampsia. There are hematological complications causing thrombocytopenia and the known HELP syndrome. uteroplacental dysfunction, which results in fetal growth restriction, fetal death, and also in abruption of the placenta and again fetal death. So from a clinical perspective, now our understanding about the preeclampsia or pregnancy-induced hypertension is in two parts. The early onset preeclampsia, which is where the preeclampsia is starting very early, maybe even as early as 20-22 weeks, and it is considered as the placental preeclampsia. And then late onset preeclampsia, which is more than 34 weeks, which is generally associated with all other medical conditions which are there with the pregnancy. Now coming to the placental preeclampsia or preeclampsia as a whole, the understanding now that we have come to is, it is more or less or actually maximally a disease of the trophoblast. Whatever problem is occurring, that is occurring from the onset of the pregnancy, and we will take a quick look as to what is happening. So, coming back to embryology, हम लोगों ने सबने पढ़ा हुआ है from our knowledge in MBBS. This is the early, very early gestation up to 8 days. We know that there is an inner cell mass and the outer cell mass. The outer cell mass is dividing into this trophoblast and a syncytiotrophoblast. The function of this syncytiotrophoblast and the cytotrophoblast is to invade. They form a villus which is actually invading into the maternal decidua. So this is a very critical thing in anybody's life. When that particular person is in the form of an embryo, it's simply not even an embryo, blastocyst. This is the cytotrophoblast, and there is also syncytiotrophoblast. The main important function of the syncytiotrophoblast and cytotrophoblast is to eat the blood vessels. So this is a schematic diagram where these are the arterioles or spiral arterioles of the uterine myometrium, which is reaching up to the decidua or the endometrium. And the trophoblast, it is actually literally eating out the spiral arterioles to the extent that all the lamina, all the muscularis has gone, and at the end of this procedure, the arteriole is left in the form of a conduit. It is simply performing the function of a pipe, allowing the flow of blood into the placental, into the fetal part of the placenta. Here is a very beautiful description or say figure which tells us that what is happening in a normal and what is happening in a preeclamptic. There is a problem with the trophoblast. This trophoblast, which is actually formed by the gamete from the male and the female gamete, that is how we are able to explain all the medical disorders, why they ultimately culminate into preeclampsia. Because all the medical disorders are causing some problem with the gamete itself. Similarly, males or husbands, how are they contributing into preeclampsia? It is through their sperms. Because that haploid which is coming into formation of the trophoblast, the function of the trophoblastic cell is governed to quite an extent by the paternal genome. And that is why these trophoblastic cells, when they are inadequately functioning, they will not invade into the vessels. So we can see that the vessel has maintained its form, and most of you are physicians, and we all know if the vessel is maintaining its form, it is exposed to all the neurohormonal changes that are happening in the body, and thus constantly either constricting or relaxing depending upon the stimuli. So this is a picture of 5 weeks of placenta and 12 weeks of placenta. Here this is a very thin artery. At that, in a normal it should turn here, but what happens when it is a preeclampsia, this vessel has not been deformed, and there is very minimal amount of flow into the placental tissue. So the placenta is actually getting ischemic. The same thing is described here. This is the normal where the intima has reduced, and in preeclampsia it is exposed to all the neurohormonal factors. So ultimately, preeclampsia syndrome, what we now understand, is a disease of the trophoblast, And the syndrome, as it shows itself, is actually the cry of a dying placenta. Whatever symptoms are happening to the mother, the hypertension, the placenta is trying to tell us that do something for me because I am dying. What is happening? Because of the placental hypoxia, there is necrosis and disruption of the syncytial structure, less amount of blood entering. Then release of placental debris, release of inflammatory cytokines, free radicals and self-propagating lipid peroxides. So ultimately resulting in systemic inflammatory response, and thus all these risk factors culminating into liver, cerebral, because there is endothelial dysfunction in every organ, there is dysfunction resulting in the multi-organ failures. So what can be done now is universal screening. Screening during early pregnancy by the first trimester combined test with maternal risk factors and biomarkers as one-step procedure. Combination of clinical factors and biomarkers which include maternal risk factors, mean arterial pressure, PLGF, that is serum placental growth factor, and uterine artery pulsatility index. So these are few clinical, few by sonography and few by biochemistry. Now Foxy or our Gestosis has developed a very beautiful score. It includes all the factors in the history which will be making the person predisposed, and a very nice HDP Gestosis app is available, and we can put all our data into that app and it gives us a high risk scoring. It is very easily available. If you just Google HDP Gestosis score, we can get all the points in the history which may make the woman prone to develop preeclampsia. Now this is SFLT1 and PIGF ratio. It is also available now with the nationalized laboratories, and SFLT1 ratio less than 38 gives us a 99% negative predictive value, so that we should be clear that it may not be. Last few words only. Once we have understood that this person is prone to develop preeclampsia, the prevention that can be done is by using aspirin. By the Aspirate trial, which was a big trial conducted, aspirin in the dose of 150 milligram daily is considered to be more helpful in reducing the PIH, in reducing the fetal growth restriction, in reducing abruption, and so on and so forth. So NICE recommendation also tells us the same. The risk factors in moderate recommendation is use low dose aspirin if the patient has one or more of the high risk factors. If there are moderate risk factors like nulliparity, obesity, family history, socio-demographic history, even age more than 35 years old, personal history, consider low dose aspirin if the patient has more than one of these risk factors. If there is a previous uncomplicated full-term delivery, do not recommend low dose aspirin. So this is the last slide. In a Fetal Medical Foundation first trimester screening algorithm, step 1 is take a good detailed history, which we all do while our first antenatal checkup. Step 2, we do biochemical as well as Doppler. Doppler is for uterine artery for pulsatility index, and PAP-A, which we are all doing in cases of as a double marker. And PIGF can also be ordered if there is a high risk in the history itself. If it's a positive screen, start with aspirin 150 milligram prophylaxis. That is what we can do as of now. So the take home messages are important. One, hypertension is a symptom, a tip of the iceberg of a sinister, ongoing and unchangeable underlying pathology. Be aware of the hidden dangers and do not consider antihypertensive drugs as the treatment. This flaw, this folly is being conducted all over. Even, I am sorry to say, even NHM has decreed us guidelines in which DIs and ANMs and ASHAs have been given the authority to prescribe antihypertensives. So it's a false sense of security. If you find hypertension, give the lady antihypertensives, send her home feeling happy that mera BP to theek ho gaya, mera condition theek ho gaya. No, so be aware that the sinister thing that is happening, all the organs that are being damaged, they are still getting damaged. Blood pressure is like fever. When there is fever, we don't satisfy ourselves by giving paracetamol. We try to find out why the fever is occurring. Similarly, where there is hypertension, we have to look for the fetus who is actually getting into trouble. If you give antihypertensive, the fetus is going to get into more trouble. Use gestosis scoring for prediction. Reducing hypertension is only of help in preventing cerebral emergencies, that is stroke, and convulsions. So we must be very clear about that. Prevention is only before conception. So the myth of prevention of preeclampsia is no more. You cannot prevent preeclampsia. As I told you, it is something related to the gametes. So improve the quality of the gametes, preeclampsia will disappear. But prediction and damage control can be done by universal screening. That is why, that is only I want to tell you. Thank you so much.
Thank you so much. Thank you so much, ma'am, for the wonderful session. Now the podium is open for the questions.
It is always a pleasure to hear and hear from you and learn from you and study. आपसे मतलब पढ़ना, teach आप. It's always a pleasure. I think all of us would agree here. And I don't think anybody has a question. किसी को कुछ पूछना? Very well explained. मैम पहले दीदी पहले तो 75 milligram aspirin का था, but nowadays
the Aspire trial, which has given us an authority telling that this is the only method by which we can at least reduce the damage. There 150 milligram is the dose recommended, but if we are comfortable with 75, because our population is a little bit different. If they are tolerating 150, fine, otherwise 75 is also okay.
Thank
और ecosprin पे already है, तो how should we proceed for it?
Second trimester में?
Blood pressure है more than 140/90 है.
Or patient is already on antihypertensive.
Yeah, no, she is on ecosprin.
On ecosprin. Actually, that is where our consideration is important, that we have to first counsel her that her hypertension indicates that there is something problematic with the placental flow. So we will give you antihypertensives, but we will have to be very highly monitoring the very intently monitoring the fetal flows, because if they know that it is fine, we are giving antihypertensive, the fetal flows may fall after some time, IUGR is going to happen, and it may not so happen that we, in trying to manage the hypertension, ultimately the baby is IUD. It is, yes, if it is 140/90, it is best to get the patient restful and all those things, and if it still remains above 100, means systolic, diastolic above 100 and systolic up to 160, then we can start with labetalol 100 milligram, that is to be titrated as we do in all our patients. Though the dosage is 100 milligram 8 hourly, we titrate it accordingly, sometimes 12 hourly, sometimes even half of labetalol tablet with whatever. Yes, the patient has to understand that this is not something कि आपने BP की गोली खा ली और आपका BP ठीक हो गया, and they also have to be sensitized. They may need a termination of pregnancy for the baby earlier, so neonatal consideration will be there. Yes. हाँ, so that is like a very difficult road to travel, because IVF से conceive किया है, they in any case they want the baby to come to 34 weeks. अगर hypertension shoot कर रहा है, because most of them are all having all other conditions and yes, तो best thing on our part is आप उनको ले जाओ जहाँ पे आपका 22 हफ्ते का बच्चा भी बचा सकते हैं, वहाँ आप ले जाओ. That is the only thing we can say. है ना? Thank you.
Thank you so much, ma'am, for your wonderful session. The next topic is on thyroid disorders. It is my great pleasure and privilege to introduce our esteemed speaker for our next scientific session, Dr. Mayur Agarwal, sir, an accomplished endocrinologist and thyroid specialist with extensive experience in the diagnosis and management of thyroid disorders. Sir has done many research works on Sheehan syndrome and Addison's disease. So, is an MBBS, MD Medicine, DM Endocrinology from SGPGI, DM Endocrinology from SGPGI Lucknow, MRCP and SC. Sir is on the editorial board of JECM CR. He is doing transpose graduates for superspecialty exams, NEET SS, and is a national secretary for Marrow, Dairy Rounds and CPCDM. So is also a chairperson for Hormone India. I won't waste much of my time and call upon Dr. Mayur Agarwal sir for his speech. I would like to request Dr. Meera Premi ma'am, Dr. Meera Bandal ma'am, Dr. Shalini Mishra ma'am, Dr. Yogesh Tiwari sir and Dr. Nishan Gupta sir to please come on the stage. Dr. Meera Premi ma'am, Dr. Meera Bandal ma'am, Dr. Shalini Mishra ma'am, Dr. Yogesh Tiwari sir and Dr. Nishan Gupta to please come on the stage.
Yeah, good afternoon everybody. At the outset, I would like to thank the organizers for inviting me and organizing such a wonderful event. Also, I would like to thank Team MKB for helping in this organization. So, today's talk, I would say, is a simple and a tough one. Simple being everybody would have seen T3, T4 reports. Tough because it's not that straightforward. Sometimes it's too much confusing, right? So thyroid test puzzle is what I am going to talk today, and it would be case based. What I request everybody is to have participation. See, this program could be seen on say YouTube also, but you are investing your time to come here to listen to me. So it should be a dialogue rather than monologue. So I'll be asking question, you would be answering, I would be answering your question, and we both would be learning from each other. So TFT interpretation is not always straightforward. It's not you see T3 report, T4 report, TSH report, you prescribe treatment. It's not like that. Sometimes the reports are different from the clinical picture. Clinical context is very important, and this will help you to recognize the pitfall, which will help you to eliminate the misdiagnosis and improper treatment. So let's talk about the thyroid test puzzles. Follow the basic rule: history, examination, then investigation, and then treatment. So let's start with case 1. Here we have a 22-year female with fatigability, got few tests in yearly package. T3 was 0.59, slightly lower, T4 4.2, lower, TSH 70. So clearly a case of primary hypothyroid, right? So do you want to replace? That means do you want to start treatment? Do you want to repeat the test? Do you want some other test? To begin with, I'll answer the first question. So this patient is 22-year female with fatigability, primary hypothyroid, TSH is raised, T3, T4 are low. So this patient requires treatment. So usually you start with some 1.6, right? So this graph, if you want, you can take the picture. This is the basic thing of thyroid interpretation, right? So whenever you have like TSH, T3, T4, everything is normal. The patient is euthyroid. Everything is normal. No confusion, right? Whenever the patient have TSH high and low FT3, FT4, T3, T4, it is primary hypothyroid like our case. You will start treatment, very simple. What is more important is this section, because now many of the patients are getting test report by themselves. You see bunch of reports, all those packages where T3, T4 are done, TSH are done without any symptoms, right? So should we treat, should we not treat, should we repeat, what other tests should be done? So that's the basic discussion today, right? So TSH if high with a normal T3, T4 is what you are dealing with, subclinical hypothyroid, right? And then vice versa, when the TSH is low and T3, T4 are high, that is hyperthyroid, right? So primary hyperthyroid. So basically you should be knowing hyper, subclinical and primary hypothyroid. So at least these 4 sections you should be very pretty clear what to treat, what not to treat. Okay. So that's the discussion today. So the standard dosing for this patient would be like 1.6 microgram per kg per day. So we have started, and the basic replacement is timing, that you should give this medicine in fasting. Thyroid की दवाई हमेशा खाली पेट ही देना है. 30 to 60 minutes the patient should not be taking anything. If by chance the patient misses one dose, the patient can take the second day, next day double dose. That is what to be done, because the half-life of your medicine is 7 days. Will not make much difference. Do not ask to take them after taking some meal. Reason being, this will impair the absorption. The cumulative dose actually changes. And then another drug, because many of here are gynecologists, should not be giving iron tablets, calcium tablets along with this medicine. At least 4 hours should be the difference between thyroid medicine and other medicine. So that's the basic thing you should be telling to your patient. Now let's continue with the same case. We have that patient. Now the patient was started on, let's say the patient's weight was 60 and we have started with 88 microgram. Now the report is T3 is 1.4, T4 is 12.8 and TSH is 27. So here you would see that T3 is normal. It was low earlier. T4 is high, even above the normal report. And TSH is also high. So what do you want? So do you want to continue with 88? Do you want to increase the dose? Do you want to decrease the dose? Do you want to repeat some test? Do you want some other test? Maybe you want USG, anti-TPO antibody, some scan. What do you want? Let it be wrong. Just answer so that we can discuss. It's not a competition. Okay. Okay. See, the basic concept of getting any test is, let us say my report is A, I will do this. My report is B, I will do this. Let us say that I am going to do path C. Should I require A or B test? No. जो भी टेस्ट करते हैं उससे इंटरप्रिटेशन चाहिए जिससे ट्रीटमेंट चेंज हो, राइट? सो व्हाट इज योर इंटरप्रिटेशन? व्हाट इज हैपनिंग टू द पेशेंट? ओके, very good. So here you have T4 high and TSH high. So do you want to increase the dose? Very good. You are getting test very, very early. And basically this patient came back after 2 weeks of replacement and patient got the test themselves. This happens very common because patient थोड़ा बहुत chat GPT पे पढ़ता है, कुछ ना कुछ करके लेता खुद ही, right? So here you are getting at 2 weeks. It will take some 4 to 6 weeks to get normalize the TSH. T4 normalizes much early, and as sir was saying, because you are giving T4 medicine, obviously it is going to be high. So nothing to do, just continue, no test required, repeat after 4 to 6 weeks. That's the basic concept. Now here we have a 30-year female without any complaint, planning for pregnancy. She got the test by herself. T3 is 1.2, T4 is 8.8, TSH is 7.8. So again, this is pretty simple, I'll answer this. So T3, T4 are normal, TSH is slightly higher, lesser than 10. This is what you call as subclinical hypothyroidism. Because this patient is planning for pregnancy, you don't need any other test, you don't require, you can just start replacement. 2.5 is cut off what you want. So subclinical hypothyroidism is where you have TSH normal with T3, T4 normal with TSH high values. That is subclinical. Basically it's a misnomer. यहाँ पे word है subclinical. It has nothing to do with clinical. Patient can have some symptom, patient may not have any symptom. It is a biochemical diagnosis. And depending on the test, depending on the clinical context, you decide whether to replace or not to replace. So you can divide into two, where you have TSH more than 10 and you can have less than 10, where T3, T4 are normal. You will call only subclinical when T3, T4 normal with a TSH raised. Now how much TSH is raised, that will decide whether this patient requires treatment or not. So if it is more than 10, most of your patient will require treatment. Elderly, you should be cautious, that is what is the guideline says. And lesser than 10 with a T3, T4 normal, most of them will actually revert back. So this graph is very, very important. See, this is a physiological compensatory mechanism. Here you can see, the pointer is not visible much. Okay, let it be. So let it be. So you can see here that the TSH rises before T3, T4 falls. So this is again very important. See, TSH is rising even before your T3, T4 is going down the normal range. So this is what is physiological change, compensatory mechanism, right? So your brain, your pituitary gives signal to the thyroid that you have to increase the hormone. So this diagram is really important to understand the basic concept of T3, T4, TSH. And before telling anybody is having a subclinical hypothyroidism, you should see when you are getting the test. Somebody recovering from some severe illness, some thyroiditis, maybe on medication like amiodarone, lithium, maybe some SA interference, maybe physiological rise because of aging, say 70 years, 80 years, you can have 7 or 8 TSH, that patient does not require treatment. Then again obesity where you have leptin resistance, slight rise in TSH, then adrenal insufficiency, because this again can give a slight rise to TSH. And then thyroid resistance is really rare, maybe one case in 3 years sort of. So how to evaluate? You get T3, T4, TSH. If T3, T4 normal with an elevated TSH, you get an anti-TPO. If positive, you treat. If negative, you see whether the TSH is more than 10. Most of the patient will require treatment. If it is less than 10, but the patient is having some symptom, maybe some goiter, some infertility, maybe planning for pregnancy or pregnant, then you treat. Otherwise, you wait and watch and follow up. That's the basic algorithm. Again, you can take a picture. That's the basic concept how you treat for subclinical hypothyroidism. Now let's move to some question. I'll be now quick because we are left with 6 minutes. So again, this 33-year male got some test because of palpitation, and T3 was 4.48 or slightly lower, T4 1.8 lower, TSH 0.5 just touching lower end. So what do you want? Do you want to start treatment? Do you want to repeat the test? Do you want some other test? Maybe anti-TPO, maybe TRAB, maybe scan, maybe USG. What do you want? Anybody? Let it be wrong. No issues. Okay. Ma'am want to repeat which test? Same? T3, T4, TSH? Okay, somebody wants FT4. Why? Why? So, I would say whenever you order the test, just think about the interpretation first. If this will come, let us say कि A आया तो मैं क्या करूँगा, B आया तो मैं क्या करूँगा. अगर मेरे को C करना है, तो A और B देख के क्या करूँगा. If you think like that before ordering any test, most of the tests can be avoided. करके देखने में दिक्कत ये है कि लेटर से कुछ ऐसा आया जिसका कोई इंटरप्रिटेशन नहीं है. अगेन यू वुड बी कंफ्यूज दैट वेदर टू नेग्लेक्ट फर्स्ट रिपोर्ट और टू नेग्लेक्ट सेकंड रिपोर्ट एंड व्हाट टू डू. सो इट क्रिएट्स मोर कंफ्यूजन देन क्लैरिटी. Anybody? What's the diagnosis? Let's sort it. History, we have palpitation. What's the diagnosis? Hyperthyroid. How many are with hyperthyroid? Raise your hands. See, basic concept when I showed you that take the picture, T3, T4 should be high. Then you would say that this patient is having hyperthyroid. Active hormone to T3 hai na. Here you are having low T3. Central hypo. Okay, pretty close. So this patient may have, I agree, and to rule out that what sir told we should get, that is FT4, because here you are telling the complete hormone, that is bound hormone. Basically only 0.3% of the T3 is free and only 0.02% of T4 is free. 70% is bound to TBG, thyroxine binding globulin. So this patient was seen later by me. He was already started on carbimazole because somebody thought it is hyperthyroid. Patient by himself stopped because nothing was happening. He himself stopped the treatment. When he came to us, this was the report, and when we got the FT4 level, it was okay. So this was just TBG deficiency, and this is an X-link. So we got the test of the daughter, and again you can see the T3, T4 are low with an FT4 normal. So it's an TBG binding deficiency. It's a normal thyroid function. We should not be treating for thyroid per se. Okay, I'll take 5 minutes of discussion in the session itself. So we have here 45-year female without any complaint, got few tests in the yearly package. T3 is 1.2, T4 is 8.8, TSH is 7.8. I'll tell you the diagnosis is subclinical hypothyroidism. So what do you want? Do you want to start treatment, repeat the test, or other test? No, without. So how many wants to start treatment? Raise your hands. Quite a few. How many wants not to start treatment? Oh, wait and watch. How many want some other test? NT-TPO?
So basically NT-TPO तो बोलेंगे but 45 year female जिसने टेस्ट कराया और आपने ट्रीटमेंट नहीं शुरू किया तो पूरे शहर भर में उस रिपोर्ट को लेके घूमेंगे और बोलेंगे आपने ट्रीटमेंट शुरू करा without
I slightly agree on that because we see such reports where 12.5 is put.
Second thing, Dr. Mayur, Madam Randa Joshi का कहना है कि 45 year female without any complaint is a rarity.
So, see, the basic of medicine is history, examination, then investigation. Now the problem is we are treating investigation, we are not treating patient, right? So patient did not have complaint, history is okay. What is important is examination. So you should examine for goiter here. So the basic again remains history, examination, investigation. This will depend on examination. You don't require any test. If the patient is having goiter, you can start treatment. Pregnancy is out at 45 obviously. So that is why I put 45 years. Young female who is obese with a BMI of 28.8 went to local physician because of obesity, got the thyroid profile, again subclinical hypothyroidism. So what do you want? How many want to start treatment? Raise your hands. 3. How many don't want to start treatment? Raise your hands. Maybe rest want to refer to me? Raise your hands. Okay. So the correct answer here, because of obesity itself, this type of TSH gets raised. If you do lifestyle management or maybe treatment if required, if the patient falls into indication, TSH will be normalized. Without any complaint, again got few tests in the yearly package with a TSH of 7.8 and the patient 1 year back was started on 12.5. Now at 1 year at 2026, the report is say 3.2. So what do you want? Do you want to stop? Do you want to continue with this report? Do you want to increase the dose, say 25, 50, whatever, or do you want some other test? So let's see. How many want to stop treatment? Raise your hands. Okay, quite a few. How many wants to continue with 12.5? The house is now more towards continue. How many wants to increase the dose? Okay. How many want some other test? Nobody wants a. So probably you should be stopping treatment. Reason being 12.5 is pretty low. This has nothing to do. I have told you that most of the patient less than 10 usually revert back by themselves. So such a pretty low dose, let us say it was here 75. And then the report was normal. You should be continuing because once you stop, again the TSH will again rise. Because when you say 75 will normalize, 25 will progress. And that will depend on NT-TPO status actually. With NT-TPO, every year 5 to 7 will actually revert to frank primary hypothyroid. Now we have lot of gynae here. So 28-year female with delivered healthy baby 3 weeks earlier and was advised 50 microgram in the second trimester. This is second trimester report. T3 is 2.3, T4 is 15.4, TSH is 7.8 and now the report is 1.3 and NT-TPO is already done there negative and the TSH at baseline was 7.8. So do you want to continue replacement with the 50 microgram? Do you want to stop treatment? Do you want to repeat or do you want some other test? Let us dissect this question. Let us say whether this was correct or not. यहाँ T3 बढ़ा हुआ है, T4 बढ़ा हुआ है, TSH बढ़ा हुआ है, still the patient was started on medicine. So how many agree with this? T3 was high, T4 was high, TSH was high. Should the treatment be given to the patient? How many say yes? Very good. So with pregnancy, because of the estrogen, the TBG increases. That is why your T3, T4 is high. And TSH is again high. This is subclinical hypothyroid where the patient should be initiated in pregnancy. The decision was correct. Now it is 1.3. So now what do you want? Do you want to continue treatment, replace treatment, stop treatment? What do you want? How many want to stop treatment? Okay, quite a few. How many want to continue treatment? Again, quite a few. How many want some other test? Any test is okay, whatever you want. So again, the guideline says if the patient is on 50 microgram, you can stop and see if the TPO is negative. Okay, and then if it is rises, again we will replace. Most of the patient are okay. That was because of pregnancy, but let us say the patient is planning for further pregnancy, you should be continuing. So pregnancy dose adjustment is usually you give 30 to 50% dose highest. On Saturday, Sunday you increase to 2 tablets. I'll just take 2 questions. we can skip, say, I'll answer this question. So primary hypothyroid on replacement 5 years and 88 microgram, and since 2 year no test, now this test is there, T3 is high, T4 high normal, T4 is high and TSH is high. So what do you want? What's the diagnosis? T3 normal, T4 high, TSH high. How many wants to continue with this 88 microgram? Raise your hands. Very good. How many want to increase the dose, say 100? Higher. How many want to decrease because the T4 is high?
No.
Nobody wants to decrease? The correct answer is again history, examination, then investigation. The problem is we are seeing investigation. We are not seeing history. See, this patient 5 years से इसने दवाई ली, 2-3 साल से कोई टेस्ट नहीं कराया, probably ये patient non-compliant है, and before coming to you, she has taken medicine. That is why the T4 has increased beyond normal and TSH is still not normalized. So what is important is compliance. So before telling that the patient is refractory, adherence is what is more important, then the assay interference, then the malabsorption celiac disease, and then you can refer for absorption test. And last 2 cases, 35 year without any complaint, got few tests, and T3 is normal, T4 is normal, TSH is above 100. So clearly this, I'll quickly answer this. This is an assay interference because of heterophile antibody. And this 42 year female with hair fall on multivitamin, T3 above reportable range, T4 above reportable range, TSH lower than reporting range. So this is biotin interference, okay? Biotin. So you have to understand this also. Again, we are not going into details. And this is the last case. 48 year female, fatigability, got few tests and low sugars. T3 is 0.19, T4 is 0.42, TSH is normal. So like we had an earlier case, here you don't require any FT4 also, right? Maybe it is thyroid binding globulin deficiency, it is possible, but you have a clinical context, right? Low sugar is because of primary, because of secondary this cortisol deficiency, okay? So this is Sheehan syndrome, very correct. So this patient has low cortisol. If you would have replaced this patient of thyroid medicine, the patient go into adrenal crisis. The patient can even die. And this last question, this is a question the organizer may give award for this, whoever answers this correctly. This is the toughest one. 45 year with fatigability, got few tests, found to have T3 of, this is random values I put, okay? T3 is 0.39, lower, T4 is 3.9, and TSH is 11, it is high. T3 low, T4 low, and TSH is more than 10. Fatigability. Okay, let us say कि ये TBG deficiency नहीं है, FT4 also we got it done, that is also on the lower end. Now, nothing because of fatigability we got the test. Primary, how many are thinking of subclinical hypothyroidism? Raise your hands. Very good. How many are thinking of primary hypothyroid? Raise your hands. Pretty close. This is not primary hypothyroid. This is secondary hypothyroid. Reason being, you are more confused here with TSH. Now again go back to that graph, physiological. Before T3, T4 falls, TSH rises like anything. It's an compensatory mechanism. जैसे आपका ये हार्मोन कम बना, थायराइड के लिए पिट्यूटरी से सिग्नल गया है कि बढ़ाओ. So with T3, T4 falling, TSH would have risen to like 100. So this is inappropriate response. So this is this is central hypothyroidism, secondary, where TSH has risen. So fatigability के साथ ही आता कई बार. See, it can be even mono. It is not always that you have 2-3 hormone deficiency. It's not always. So to treat or not to treat will depend on the clinical context, history, examination, investigation. So we have to treat the patient, not the report. Thank you.
Thank you so much, sir. Due to the time restrictions, we will not be able to take the questions. We'll take it in the lunch session. Thank you so much, sir, for the wonderful session, sir. And I'll request our chairpersons and our speaker to please proceed to the felicitation area for the felicitation. I would now like to request Dr. B.L. Rajput, sir, Dr. Ashok Singhal, sir, Dr. Shashank Gupta, sir, and Dr. Vivek Rathi, sir, to please come on the stage for the chairperson. Our next session is of Dr. Narmada Patil, sir. As India marches towards 2047, that is 100 years of independence, we aspire to become a healthier, stronger, and more prosperous nation. But standing in the way is one of the most greatest public health challenges of our generation, that is diabetes. To share the vision, strategies, and roadmap for the ambitious stuff, it is my honor and privilege to invite Dr. Narmada Patil, sir, to address on the topic Battle Against Diabetes in India, Mission 2047.
Thank you, sir. So, good afternoon. Namaste. It is a privilege to be here, speaking in front of a very elegant team of doctors. और मुझे लगता है कि ये सब लोग एक कॉमन कारण से यहाँ पे इकट्ठे हुए हैं और कहीं ना कहीं ये मिशन मेरे मिशन से मैच करता है. I see lot of senior people, Vrinda madam, sir. So all of them have come here for some reason. Can I have my slides? So today I will be speaking on a very important public issue. हम सब लोग यहाँ IMA के बैनर में इस मेडिसिन अपडेट का समागम कर रहे हैं और मुझे बहुत खुशी है कि ना केवल फिजिशियंस, endocrinologists and from the field of medicine people have come here, rather all the fields people have come here. Okay, so I would like to take this talk from down. So my mission is Mission 2047, preparing India for battle against diabetes. ये purposefully इस टॉपिक को चूज किया गया है क्योंकि मेरा ऐसा मानना है और मैं ऐसा सोचता हूं कि आने वाले समय में ना केवल फिजिशियन एंडोक्राइनोलॉजिस्ट बल्कि सब लोगों को डायबिटीज को ट्रीट करना होगा, बी इट अ गायनेकोलॉजिस्ट, बी इट अ ऑर्थोपेडिशियन, बी इट अ डेंटिस्ट, बी इट इवन होम्योपैथी परहैप्स, because the type of tsunami we are going to have in the coming years is immense and probably we need to understand the details about it. So this is the idea for the vision मोदी जी का मिशन है विकसित भारत 2047 और हम लोगों से ये सुझाव मांगते रहते हैं कि टुडे द गोल ऑफ द कंट्री इज विकसित भारत, शिक्षित भारत. वी कैन नॉट स्टॉप अंटिल दिस ड्रीम ऑफ डेवलप्ड इंडिया इज फुलफिल्ड. और इसके बारे में पूरे मीडिया में चर्चा चल रही है कि इंडिया को कितना रिच होना चाहिए, हाउ रिच मस्ट इंडियंस बी फॉर इंडिया टू बी कॉल्ड डेवलप्ड. क्या लेकिन पैसा कमाने केवल से इंडिया विकसित भारत बन जाएगा? ये अगला कटिंग टाइम्स ऑफ इंडिया 2024 से है, वर्ल्ड डायबिटिक डे, जो ये कहता है, लैंसेट में रिपोर्ट पब्लिश हुई है, 90% ऑफ इंडियन डायबिटिक पेशेंट स्टिल और अनट्रीटेड. इंडिया इज द कैपिटल ऑफ अनट्रीटेड डायबिटीज. और उसके बाद ये अभी 2025 में नेचर में पब्लिश होता है, जो दैनिक भास्कर की कटिंग है, जो ये कहता है कि इंडिया की डायबिटीज लोगों की ट्रीट करने की जो कॉस्ट है, इट इज गोइंग टू बी 138 years डिफेंस बजट ऑफ इंडिया. यानी कि 138 साल के डिफेंस बजट का खर्चा केवल एक साल में डायबिटीज के ट्रीटमेंट पे हो जाना है. ये नेचर में पब्लिश हुई है, जिन्होंने वर्ल्ड के अलग अलग देशों को स्टडी किया है. और ऐसा खर्चा क्यों? ये पब्लिक डोमेन में है बात, वहां चर्चा चल रही कि मरीजों की संख्या लगभग 25% दुनिया के डायबिटीज के पेशेंट इंडिया में हैं. अभी थोड़े दिन पहले हम लोगों ने कोरोना को विटनेस किया. कुछ 4 करोड़ लोग कुल 2.5 साल में बीमार पड़े और कोरोना 2-4-10 दिन की बीमारी थी. जिसने पूरे देश को हिला के रख दिया, और हमको एक स्ट्रैटेजी के तहत, एक प्लान के तहत उसको ट्रीट करना पड़ा, और थोड़े दिन में पूरी कंट्री रुक सी गई थी। जबकि यहां पे फिगर कुछ और है जिस पे हम ध्यान ही नहीं दे रहे। और ये 10 दिन की बीमारी नहीं है, इसकी लाइफ लॉन्ग इसका इलाज चलना है। सबसे इंपॉर्टेंट बात, इट इज अफेक्टिंग द वर्किंग पॉपुलेशन ऑफ इंडिया। यंग लोगों को अफेक्ट कर रही है, एंड द केयर प्लान इज नॉट फॉर फ्यू मंथ्स, few years, rather it is lifelong. So it is probably something which probably we are not understanding. So let us discuss something about it. So India carries one of the world's largest diabetic load. चाइना के बाद दूसरा नंबर हमारा है। नंबर चाइना के पास ज्यादा है, लेकिन दुनिया में जो अनट्रीटेड डायबिटीज है उसमें सबसे ज्यादा नंबर हमारा है। ये केवल बाहर का डाटा नहीं कह रहा, केवल आईडीएफ का एटलस नहीं कह रहा है कि वहां पे करीब करीब 9 करोड़ लोगों को डायबिटीज है, बल्कि इंडिया की खुद की आईसीएमआर की स्टडी जो पिछले 12 साल में उन्होंने रोबस्ट सर्वे किया, आईसीएमआर इन-डेप्थ स्टडी व्हिच हैज बीन पब्लिश्ड इन लैंसेट 2024, इट टेल्स दैट देयर आर 10 crore people, 101 million people with diabetes currently living in India, and 13.6 crore, that is 136 million persons with pre-diabetes in waiting में है। इनका प्रपोर्शन अलग अलग है, जिसके बारे में और भी बहुत सारा डिटेल है। 47% ऑफ द डायबिटीज रिमेन अनडायग्नोज्ड, लोगों को पता नहीं है। जिनको पता है उनमें से ट्रीटमेंट कितना ले रहे हैं ये भी अलग एक मुद्दा है। सो ऑलमोस्ट 1 in 7 person in India will have diabetes. India is untreated diabetic capital of the world, ऐसा जो लैंसेट कहता है। और ये सेम बात केवल लैंसेट नहीं कह रहा है, हम लोग विदेशी लोगों को कहते हैं कि वो हमारे बारे में अनर्गल बातें करते हैं। ये नेशनल फैमिली हेल्थ सर्वे का डाटा जो पब्लिश हुआ है 2025 में, वो भी ये कह रहा है कि 73% ऑफ द पीपल रिमेन अनअवेयर, 79% आर नॉट ऑन एनी काइंड ऑफ ट्रीटमेंट, 93% of those on treatment are not controlled. They are not achieving the 3 goals of lipid, blood pressure and diabetes. So out of 100 persons being treated, only 7% reaches their goal for diabetes, blood pressure and cholesterol. And why there is a surge? हम सब लोग बात करते हैं हम तो इंडियन हैं, कृषि प्रधान देश के लोग हैं, हम में तो हो ही नहीं सकता, because rapid urbanization, migration to cities, sedentary industrial lifestyle, we are all witnessing. Nutritional shift, हम लोग अभी डाइट की बात कर रहे हैं, डॉक्टर प्रॉमिस, डॉक्टर अभिषेक लो कार्ब एंड लो कैलोरी डाइट की बात कर रहे थे। There has been lot of change in last 3 to 4 decade. Aging and growth, जहां पे आजादी के समय पे हमारी एवरेज सर्वाइवल एज 39 थी, आज वो 73 है। एंड अनइवन पेस, इंडिया के अंदर जो स्टेट्स हैं वो अलग अलग पेस पे चल रही है। केरल एक राज्य है जहां पे इन्फेंट मोर्टेलिटी, मैटरनल मोर्टेलिटी यूएस के एवरेज से बेहतर है। केरला's IMR and MMR is better than that of United States of America. And उसके काउंटर पार्ट में मध्य प्रदेश, हम लोगों का राज्य, ऐसा प्रदेश है जिसका मैटरनल मोर्टेलिटी, इन्फेंट मोर्टेलिटी इंडिया में तो सबसे ज्यादा है ही, पर उसका जो एवरेज है वो युगांडा और साउथ अफ्रीका से वर्स है। और हम लोगों की इसकी जानकारी नहीं है, हम अपने आप में फूले नहीं समाते कि वी आर डूइंग अ ग्रेट जॉब। ऑफ कोर्स वी आर डूइंग, बट प्रॉब्ली यदि हम लोग इसके आउटकम की चर्चा करें तो हम अभी वहां पे स्टैंड नहीं करते। रिस्पेक्टेड मैडम अभी कह रही थी कि दूसरे लोगों को हाइपरटेंशन के लिए दवाई स्टार्ट करने का गवर्नमेंट को कुछ करना पड़ा, तो मैडम वो मैं उसको सही नहीं ठहराता हूं, लेकिन मैडम हमारी डॉक्टर्स की, डॉक्टर कम्युनिटी की प्रोडक्टिविटी, इट इज वेरी वेरी लो। That is reflected on these 2 national reports, ICMR in-depth study and National Family Health Survey. So this is the ICMR in-depth study. I hope most of you must be aware. This has been adult survey, more than 20 years of age, held in 31 states and UTI, held from 2008 to 2020 survey window that was happened in 5 phases, funded by ICMR, and it used a robust tool that is OGTT and HbA1c, gold standard diagnosis, and it tells that there is a uniform gold standard method which has been employed, and the prevalence has been recently discussed by me, and the full metabolic burden is not limited to diabetes alone. 10 करोड़ लोग केवल डायबिटीज के हैं ऐसा अकेला नहीं है, 35 करोड़ हाइपरटेंशन भी हैं। करीब करीब ऑलमोस्ट ऑफ दो सर्वेड 81% of them had dysglycemia, huge burden. एंड यदि हम इसमें रूरल और अर्बन की बात करें तो थोड़ा सा शहरों में ज्यादा है, लेकिन गांव भी पीछे नहीं है. और ये गांव हमारे वो हैं जहां पे कोई इंफ्रास्ट्रक्चर नहीं है, हमारी कोई तैयारी नहीं है, और ये हमें पता भी नहीं है. एंड सबसे बड़ी बात, जहां तक इंसिडेंस एंड प्रेवलेंस की बात करें तो डायबिटीज का जो इंसिडेंस प्रेवलेंस है, इट इज मोर इन साउदर्न स्टेट. वहां पे केरला, तमिलनाडु, आंध्रा, तेलंगाना, it is far higher, but then the epidemic has matured. The number of pre-diabetes, that is the waiting persons to become diabetes, is far less. Epidemic has matured, but Madhya Pradesh, Rajasthan, Uttar Pradesh, यहाँ पे ये epidemic accelerate होना है. And I believe कि हम सब लोग इस चीज को रोजमर्रा में witness कर रहे हैं कि हर किसी को डायबिटीज की, साहब ये मेरी रिपोर्ट बड़ी कैसे आ रही है, ये कैसे मेरी रिपोर्ट बड़ी, हम इसको रोज विटनेस कर रहे हैं. तो there is a thing where the epidemic is mature, where the number of pre-diabetes and diabetes is 1:1, and there is a area in the state like the central region, Madhya Pradesh, Uttar Pradesh, Rajasthan, where this pre-diabetes to diabetes ratio is 2:1. यानी रफ्तार अभी बहुत तेज होनी है. उसके लिए हमें इसकी कुछ तैयारी करनी, जिसके बारे में मैं आपसे बात करने आया हूं. स्लाइड्स में कुछ प्रॉब्लम है. सो द प्रॉब्लम इज डायबिटीज इज अराइविंग अर्ली इन इंडिया. ऐसा नहीं है कि केवल डायबिटीज आ रही है, जल्दी आ रही है, जल्दी आ रही है. वेस्ट में भी 50 साल पे आती है, यहां 30 साल पे आ रही है, और 30 साल के बाद उसे अगले 50, 60, 70 साल आपके साथ रहना है. एंड यू नीड टू प्रोवाइड केयर फॉर योर कंट्री मैन. सो इट इज कमिंग अर्ली. इट एक्सपोजेस लॉन्गर लाइफ टाइम फॉर हाइपरग्लाइसीमिया. स्ट्राइक्स ड्यूरिंग द पेशेंट मोस्ट प्रोडक्टिव वर्किंग ईयर्स. 35-40 साल के हमारे बैंक एम्प्लॉय, हमारे डॉक्टर, हमारे जितने भी शिक्षा कर्मी हैं, जितने भी लोग हैं, उनको ये अफेक्ट करती है. इंडियन स्टेज इन नॉर्मोग्लाइसीमिया ओनली फॉर 30 to 40 या शॉर्टर देन द वेस्ट. वहां जहां 50 साल वो नॉर्मोग्लाइसीमिया होता है, अपन लोग कम रहता है. आई विल बी लिटिल फास्ट बिकॉज कपल ऑफ मोर थिंग्स. सो दिस इज द सेकंड सर्वे, नेशनल फैमिली हेल्थ सर्वे. वहां पे पब्लिश्ड है ये चीज, जहां पे बताया गया ओनली 27% ऑफ योर पॉपुलेशन इज अवेयर ऑफ डायबिटीज, 21% इज टेकिंग of those who were diagnosed are taking treatment, and only 7% is under control. So the factor contributing to poor outcome, क्यों 7% control है, क्यों हमसे नहीं हो रहा, is because of lack of awareness, poor acceptance. आप यदि किसी को अवेयर भी है, आप दे भी देते तो फॉलो नहीं करता है. lack of education, this is the most important thing, and this is the single thing which brings me and my seniors from distant part of the country to this सिटी ऑफ मुरैना, कि हम लोगों को एजुकेशन पे काम करना है. कॉस्ट ऑफ कोर्स, पुअर एडहेरेंस, इनएडिक्वेट यूटिलाइजेशन ऑफ अवेलेबल रिसोर्सेज. जो रिसोर्सेज अवेलेबल भी हैं उनका भी हम ठीक से यूटिलाइज नहीं कर पा रहे हैं. फेलियर टू एक्ट ऑन डेफिशिएंसी, हम लोग उस चीज पे काम नहीं कर रहे जिस पे करना चाहिए, जिससे कि सो साइकोलॉजिकल फैक्टर्स. इंडियन फिनोटाइप से डिस्टिंक्ट फिनोटाइप वेयर इट because of low birth weight, undernutrition, diabetes strike early. We have a different body composition, we have metabolic abnormalities, we have clinical outcome which may be variable. I'll go a little fast. South Asian bodies are different because of multiple things. And Central India, the place where we are practicing, it's a special case, जहां awareness भी नहीं है, जहां पे infrastructure भी नहीं है, population तैयार भी नहीं है, acceptance भी नहीं है. और ऐसा केवल मैं नहीं कह रहा हूं, ये नेशनल फैमिली हेल्थ सर्वे का डाटा कह रहा है. हम सब लोगों ने एक स्टडी की थी जो क्यूरियस में पब्लिश हुई थी, जिसमें ये बताया कि डायबिटीज हाइपरटेंशन का जो कॉम्प्लायंस रेट है, इट इज अप टू द मार्क ओनली इन 10% ऑफ पीपल. दिस इज द स्टडी डन बाय आवर ओन पोस्ट ग्रेजुएट एंड माई सेल्फ. सो दिस इज अ फैक्ट. एंड सो देयर हैज बीन अ चेंज इन द पॉलिसी नाउ. दिस पोजिशन स्टेटमेंट which has been issued by RSSDI recently only, 2 months back, talks on the pre-diabetes and type 2 diabetes mellitus for diagnosing them early, taking a tool which is known as Indian Diabetes Risk Score, which doesn't even involve any blood test. You can download it from the, you can have this in the group, so I will provide it to you, wherein the patient can be diagnosed even without, to some extent, who should be screened, can be diagnosed, who is at risk of pre-diabetes and diabetes can be done. So there is a population given which need to be diagnosed, and why it need to be diagnosed, you also need to do community screening. So that might involve age, waist circumference, physical activity and family history. So that can be used on you can also use a Google form and you can take use of the digital tools. आप उसको अपने ग्रुप पे डालिए और देखिए कि कितने लोगों को टेस्टिंग की जरूरत है, कम्युनिटी में आप उसको यूज कर सकते हैं. So there is a simple graded risk model for progression to type 2 diabetes. So now RSSDI is saying you need to target pre-diabetes so as to stop them from becoming diabetic. So cardiovascular risk, और ऐसा नहीं है कि pre-diabetes में हम लोग डायबिटीज की दवाई स्टार्ट नहीं कर रहे तो आप बचे हुए हो. It is not like that. Once you are in pre-diabetic range, your odds of having acute coronary syndrome increases by 2%. 2 times. You will have double the rate of acute coronary syndrome. You will have acute ischemic stroke, 2.21% odds ratio. You will have an odds ratio of 1.41, acute heart failure. So the risk is continuous. जैसी pre-diabetes होती है, भले ही आप anti-diabetic start नहीं करें, but its risk of cardiovascular and cerebrovascular disease increases disproportionately. The natural history of pre-diabetes in India is compressed. It is fast. Lifestyle modification is the foundation of care. जहां पे हम लोग लार्ज चंक ऑफ पॉपुलेशन में मैसेज को परकोलेट करने में फेलियर रहे हैं कि 50% ऑफ द 5 to 10% of weight loss need to be targeted. You need to define and limit the carbs, which are refined carbohydrate, and calorie dense food has to be restricted. More fiber and whole grain need to be involved, and more physical activity need to be promoted. And we already discussed that this green revolution, economic liberalization, and today's digital era is actually fueling this epidemic. And I tell you one very important thing. This is a man very popular in South, Dr. Devi Prasad Sethi. इनका ये कोट मुझे बहुत हिट करता है. If the solution is not affordable, it's not a solution. यदि कोई सॉल्यूशन आपकी पब्लिक अफोर्ड नहीं कर सकती है तो साहब वो आपकी सॉल्यूशन की लिस्ट में इरेज कर देना चाहिए. यदि आप GLP अफोर्ड नहीं कर सकते, लेट्स नॉट टॉक आउट GLP. इफ यू कैन नॉट अफोर्ड एनी कॉस्टली ड्रग, लेट्स नॉट डिस्कस इट. इट मे बी गुड फॉर साइंस बट इट्स नॉट गुड फॉर कम्युनिटी. आज हमसे हमारे डॉक्टर्स का ट्रस्ट क्यों कम हो रहा है? बिकॉज प्रोबेबली हम अपनी पॉपुलेशन के बेनिफिट में बात नहीं करते हैं. तो हमारी पॉपुलेशन ये समझती डॉक्टर को सिर्फ अपनी जेब भरने की और पर्स बनने की चिंता है. और आई टेल यू कि दिस में बी हार्ड ट्रूथ, बट प्रोबेबली इसमें वो पार्टली राइट भी है. मैं ऐसा नहीं कहता कि लोग करना नहीं चाहते, लेकिन हमारा आउटकम पुअर है. सो द प्रोग्राम, वी नीड टू इवेल्युएट आवर पॉलिसीज, वी नीड टू फोकस ऑन प्रिवेंशन, वी नीड टू focus on delay of diabetes, we need to focus on remission of diabetes, we need to diagnose them early, we need to provide affordable and accessible care, acceptable care. आप बोलिए उसको पैदल चलने के लिए, आपसे नहीं, आपकी बात नहीं सुनना तो ऐसे आदमी से बुलवाइए जो उसकी बात वो सुनता है. Prevention of complication, reorientation of health priorities, and we need to focus on strategies which work. जो काम करती हैं स्ट्रेटजी, उन पे आपको फोकस करना है. So you need to remember these 9 figures. 101 मिलियन यानी 10 करोड़ लोगों को डायबिटीज है, 13.6 करोड़ लोगों को प्री डायबिटीज है, 73% अनअवेयर हैं, 79% अनट्रीटेड हैं, 93% अनकंट्रोल्ड हैं. दुनिया भर की दवाइयां सब कुछ मिला के 7% पे केवल पॉपुलेशन ऐसी जिसको ट्रीटमेंट का फायदा मिलने वाला है. 81% को डिस्लिपिडीमिया है, 35% को हाइपरटेंशन है. आपकी टॉप टू बॉटम प्रिवेलेंस का डायबिटीज का प्रोपोर्शन 5 times टू द लोअर थिंग. मतलब एमपी की स्टेट में यदि लोएस्ट आप मानते हो तो गोवा में हाईएस्ट है 5 गुना. एंड ओनली 7% ऑफ देम आर ऑन टारगेट. एंड वी नीड टू इन्वॉल्व सर्टेन थिंग्स विच विल इंप्रूव द आउटकम, विच माइट इन्वॉल्व शेयर्ड डिसीजन मेकिंग. जैसे हम अभी अग्रवाल से बात कर रहे थे गेस्टेशनल डायबिटीज पे, बहुत सारा कंफ्यूजन है गाइडलाइंस में. वी नीड टू गो फॉर सिंपल सॉल्यूशंस, सिंपल सॉल्यूशंस. और इसको प्रिवेंट करना, नॉन कम्युनिकेबल डिसीज को प्रिवेंट करना कोई बहुत मुश्किल नहीं. वी नीड टू डू सिंपल थिंग. एक्सरसाइज, योगा एंड लाइफस्टाइल रिमेन्स द कॉर्नरस्टोन ऑफ द थेरेपी. एंड वी नीड टू, सो टेक होम मैसेज व्हाट मे बी डन. प्रमोट हेल्दी लाइफस्टाइल बाय मास लेवल एजुकेशन. इंप्रूव एक्सेस टू हेल्थ केयर बाय all the members, by making a team, involve all dentists, involve all IMA members, involve everybody. Let us work as a team. Also involve CHO, nursing staff, ASHA workers. Support research and innovation. Local. हमारे सवालों का जवाब अंग्रेज नहीं देगा साहब, वो अपनी कंपनियों का फायदा देखेगा, उसको वो चीज प्रमोट करनी है। हमारे लोगों के लिए हमें काम करना है। इन्वेस्ट इन मेडिकल रिसर्च टू डेवलप बेटर प्रिवेंटिव स्ट्रेटजीज, treatment and cure for diabetes suitable to the local population, encourage collaboration between government, academia and private sector to innovate certain things in diabetes care। और मैं ये बात केवल ऐसे खाली पीली कह नहीं रहा हूं, भाषण देने के लिए नहीं, मुझे मालूम है आप सब लोग ये काम बहुत अच्छे से कर रहे हो, आप सब लोग ये काम बहुत अच्छे से कर रहे हो, बट लेट्स जॉइन हैंड, लेट्स गिव अ स्मॉल एफर्ट। हम लोग छोटा मोटा कुछ कुछ करते रहते हैं। आई टेल यू समथिंग, एक छोटा सा मिशन मैं ड्राइव करता हूं, मेरा गांव मेरी जिम्मेदारी। आसपास के जैसे ये मुरैना डिस्ट्रिक्ट है, सीहोर डिस्ट्रिक्ट है, वहां के पॉपुलर गुरुदेव हैं, इनको आप जानते होंगे, डॉक्टर प्रदीप मिश्रा। यदि हमारी बात नहीं सुनेगा, उनके मुंह से सुनेगा। वी होल्ड मीटिंग लाइक दिस इन्वॉल्विंग IMA, this we hold in, there is district nearby to Bhopal, Nandapuram, involving the very popular MP of that, Darshan Singh Chaudhary. This is my wife contributing to this. These are all CHOs. We did it in Riva. So we are doing, and we are also involving the research component. This is the workshop done in Allen Medical College on the very first day of joining of 150 postgraduate students. So we are doing it, and I thank everybody of you for coming here and contributing to this mission 2047, because हम सब लोग कर रहे हैं unnoticed तरीके से। But let's join hand, let's give something very productive so that we can also contribute to the country to become developed. Thank you very much.
Thank you so much, sir. Thank you so much for the wonderful session. Since we are running out of time, we won't be having any discussions right now.
Sir. If you talk about cost, weekly insulin is something which comes in the same domain. हम लोग अभी क्या है, डॉक्टर का जो सिनेरियो है, डॉक्टर हैज बिकम ब्रांड एम्बेसडर ऑफ मेडिसिन एलोन। डायबिटीज का ट्रीटमेंट केवल मेडिसिन नहीं है, द कॉर्नस्टोन रिमेन्स लाइफस्टाइल। हम लोग उसकी बात ही नहीं करते हैं। वीकली इंसुलिन इज अ वंडरफुल ऑप्शन फॉर सूटेबल कैंडिडेट्स। Sir, research thing, sir, they are happening across medical college. You can also contribute to it by providing data. Research का मतलब केवल ये नहीं है सर कि जो पेपर लिखेगा, you can provide data and that can be done in collaboration. कुछ बच्चे बहुत अच्छे पेपर लिखते हैं, कुछ लोगों का साइंटिफिक, somebody can contribute with idea, somebody can give data. लोकल का डाटा हमें चाहिए सर, everybody can contribute. Yeah. Yeah, that's what I'm telling you, sir. These two robust data are not private data. ICMR की स्टडी है 2008 से 2020 तक 31 स्टेट्स में स्ट्रक्चर्ड तरीके से करी गई है। ये जो डाटा है, ये गवर्नमेंट का डाटा, नेशनल फैमिली हेल्थ सर्वे का डाटा, ये गवर्नमेंट का मिनिस्ट्री ऑफ फैमिली हेल्थफेयर का डाटा है। जो बात आप कह रहे हैं कि इसको लोअर डाउन कर दिया गया है, a government study, big study happened in AIIMS Delhi has revealed more than 50% of the heart attack in India are happening below the age of 45 years. 45 साल के नीचे हो रहे हैं। And if you see the Indian guidelines for cholesterol lowering, you would see that the cholesterol levels has been lowest among the world, issued by the Indian guidelines. अभी आप लाल की कोई भी रिपोर्ट या किसी भी पैथोलॉजी की नई वाली गाइडलाइंस उसमें छपी होती हैं, देखिए। अब गवर्नमेंट के साथ प्रॉब्लम ये है कि प्रॉब्लम इतनी बड़ी है कि वो ओपनली बोल नहीं सकते. You see any report of lal pathology or any reputed lab, you will see the Indian guidelines available there. They are far lower than that, what has been recommended by West. Our population is different. We need to focus on lifestyle. That can only save us. Thank you.
Thank you so much, sir. Due to the short time, we won't be taking any more questions. The next session is on movement disorders. I would like to request our speaker, sir, and our chairperson, sir, to please go to the felicitation center for our speaker's felicitation. I would like to call Dr. Dilip Premi, sir, Dr. Vikas Sharma, sir, Dr. Rakesh Sharma, sir, and Dr. Arvind Garg, sir, for being the chairperson for the next presentation. The next presentation is on movement disorders by Dr. Dinesh Udinia, sir. Movement is something we often take for granted until the nervous system loses its ability to control it. And to unravel the complexities of the fascinating field and translate them into practical clinical insights, I would like to request each and everyone to please join me in welcoming Professor Dr. Dinesh Udinia, sir, Professor and Head, Department of Neurology, Jayarogya Hospitals, Gwalior. So please, the podium is all yours. After the next two sessions, Mr. Asid Yadav, sir, will come for the inauguration ceremony along with our CHMO, sir. So please.
आप सभी को मेरा नमस्कार. मेरे ख्याल से पहली बार मैं देख रहा हूँ कि चंबल ग्वालियर से आगे निकल गया. कि मतलब मेडिकल अपडेट मैंने ग्वालियर में भी नहीं देखी इतनी बड़ी, जो इतने सारे स्पीकर्स आपने बुलाए सभी जगह से और सारे टॉपिक कवर किए, कार्डियोलॉजी, न्यूरोलॉजी, एंडोक्राइनोलॉजी, रिमेटोलॉजी, और इसके अलावा आईएमए की तरफ से भी अगर देखा जाए तो ग्वालियर आईएमए ने इस तरह की कॉन्फ्रेंस अभी तक तो मैंने नहीं देखा कि उन्होंने अटेंड कराई है. तो इसके लिए भी मुरैना आईएमए को साधुवाद. बहुत बड़ा काम आपने अचीव किया है और मैं ग्वालियर आईएमए को इसका मैसेज कन्वे करूँगा कि कुछ प्रेरणा लें मुरैना आईएमए से और आगे बढ़ने का प्रयास करें. थैंक यू. आज का मेरा टॉपिक है मूवमेंट डिसऑर्डर, जो बहुत न्यूरोलॉजी में नेग्लेक्टेड पार्ट रहता है. यूजुअली हम देखते हैं तो उसको उतना ज़्यादा समझ नहीं पाते. तो मेरी आज की ये कोशिश है कि आपको वीडियो दिखा के कुछ जो कॉमन मूवमेंट डिसऑर्डर है आप उनको रिकॉग्नाइज कर सकें और जो ट्रीटेबल एंटाइटी है जिनको हम ठीक कर सकते हैं उनको आप पहचान के ट्रीट कर सकें. नेक्स्ट. So what is the movement disorder? Movement disorder is a heterogeneous group of neurological condition characterized by reduced movement disorder like akinesia, bradykinesia, or excessive involuntary movement known as a dyskinesia. Next. So first we will discuss hyperkinetic movement disorder, later on hypokinetic movement disorder like Parkinsonian. Hyperkinetic disorder divided into 5 major groups. One is tremor, which is the most common in clinical practice. Second is dystonia. Third, athetosis. Fourth, chorea. Fifth, myoclonus. And tics usually encountered in clinical practice of psychiatrists. So, any movement disorder patient if come in your clinic, 10 questions should be asked or by the observation. First is distribution, second is rhythmic or arrhythmic, third is speed, super fast, fast, slow, third is amplitude like ballistic movement or slow movement, fifth is frequency, high frequency, low frequency, and what is the pattern? Pattern means particular similar group of muscles repetitively, suppressible, trigger factor, and the distractibility, and last one is entertainment. Next. So case-based approach. This patient is come in neurology OPD. Anyone guess what is this movement? 68-year-old right-handed male patient present with 5-year history of gradually progressive bilateral shaky hand movement aggravated during voluntary activity. The movement worsen with stress, does not interfere with sleep. This is also intermittent head tremor. Positive family history of similar movement in his father. Anyone? No. Again, we look first distribution. Distribution is in upper limb, not in lower limb. Distal part, hands, not the proximal part. And rhythmic. Rhythmic activity, speed is not fast, not super fast. Frequency usually 8 to 10. Pattern is non-pattern movement. Trigger movement by the voluntary activity. Suppress on the rest. No distractibility, no entertainment. So it is the most common clinical disorder in neurology clinic is tremor. So tremor is essential tremor. Three type of tremor. One is the essential tremor, second is the Parkinson rest tremor, and third is the cerebellar tremor. Most common is essential tremor, after that Parkinson tremor, third one is the cerebellar tremor. So diagnostic criteria of essential tremor, usually isolated tremor syndrome, not any other activity like athetosis, chorea or dystonia. At this 3-year duration, this patient have a 5-year duration. And with or without tremor in other location, this patient having the head tremor. Absence of other neurological sign. So this is the criteria for the essential tremor. This is a familial history, hereditary essential tremor. Works with goal-directed activity, disappear on the rest, 4 to 12 hertz, often improve transiently with the sleep. And also ask the history of alcohol. Alcohol usually relieve the essential tremor. 20% have a rest component, familiar in 50 to 70% cases, usually autosomal dominant pattern. So diagnosis is essential tremor. Treatment choice is propranolol, first line, second is the primidone. But many times we give the gabapentin or topiramate. Next. This is the another case. Anyone can guess. This is again tremor. This is only the tremor. This is the rest tremor. You can see this is a pill rolling tremor. Pill rolling means जैसे माला जपते हैं, आइए तो माला जपने वाला जो मूवमेंट है वो वाला मूवमेंट को पिल रोलिंग ट्रेमर कहते हैं. ये करेक्टरिस्टिक फीचर ऑफ पार्किंसन यूजुअली स्टार्ट यूनिलेटरल, एक ही साइड से स्टार्ट होता है पार्किंसन. एसेंशियल ट्रेमर जो था लास्ट वाला वो बाइलेटरल प्रेजेंट करता है, ये यूनिलेटरल प्रेजेंट करेगा. सो अकर एट द रेस्ट सप्रेस्ड बाय द वॉलंटरी एक्टिविटी, इसको मूवमेंट करने से ये डिसअपियर हो जाएगा, जबकि वो एसेंशियल ट्रेमर एक्टिविटी से बढ़ रहा था. दैट इज द अपोजिट. फ्रिक्वेंसी 4 to 6 hertz. There is the 8 to 12 hertz, usually asymmetric onset. Next. So rest tremor is a Parkinson postal tremor characterized by reappearance of rest tremor. These are the tremor usually disappear by the voluntary activity, but again on the reposture reappear. In this case, दोबारा से दिखा इसको वापस. Disappear, now again appear. This is a rest tremor of Parkinson. So it's called the re-emergent tremor. Next. So tremor is rest tremor, action tremor. Rest tremor is usually Parkinson, where occur when body part is completely supported and disappear with voluntary activity. Action tremor divided in again postal tremor like essential tremor, kinetic tremor simple like essential tremor, intention tremor, cerebellar tremor, isometric tremor, and task specific like Ralther cramp, and position specific dystonic tremor. Next. So this is another case of hyperkinetic movement disorder. A 21-year-old woman present with 2-year history of progressive painful twisting posture of the left hand, initially episodic but now occurring daily. 1 year later, similar abnormal posture involved the left foot, causing the difficulty in walking. These movements are sustained, unilateral, worsen with activity, improve in the morning. Anyone diagnosis? दोबारा से चला दे video. This one. Again same question, distribution, left side unilateral, not generalized, arrhythmic, speed is very slow, amplitude is very low, pattern, repeated pattern, same muscles group is involved. Yes. This is the dystonia. Hemidystonia. So hemidystonia usually secondary to structured lesion. MRI brain shows the right basal ganglia and encephalomelic lesion consistent with remote structural insult. Management try through pacitane and supportive physiotherapy. Clinical outcome look good. Significant improvement in dystonic posture. Next. No. Pichalo. Yes. This is the dystonic tremor. Same patient, left side, tremor occurring the body part affected by the dystonia. Next is. This is the null point, is a specific position of the affected body part where the dystonic posture and tremor are markedly reduced. In this video, reduce the irregular plus asymmetric, dystonic posture plus sensory tremor. So this is the dystonic tremor. Next. This is another case of hyperkinetic movement disorder. 9-year-old male child presented with decline in school performance since 1 year and abnormal posturing involving neck, trunk and all 4 limbs since 8 months. Okay. Distribution, generalized. Rhythm, irrhythmic. Speed, slow. Pattern movement. This is a mixed movement, not a single movement. 2 movements are occurring. So this is the this is the generalized dystonia. Young female. So we do the slit lamp ophthalmoscopy for KF ring, 24-hour urinary copper and serum ceruloplasmin for Wilson disease, which is the commonest cause of the young onset movement disorder. So in this case, slit lamp examination positive, serum ceruloplasmin low, 24 urinary copper is elevated, MRI brain show the bilateral potamen and caudate nucleus T1 hyperintensity. So diagnosis is Wilson disease presenting with generalized dystonia. Treatment initiated D-penicillamine with gradual dose escalation and pyridoxine and zinc oxide. After the treatment, patient improved. So dystonia is a movement disorder characterized by sustained or intermittent muscle contraction causing abnormal, often repetitive movement, posture or both. Dystonic movements are typically pattern, twisting and may be tremulous. Dystonia is often initiated or worsened by voluntary action and associated with overflow muscles activation that cause semi-purposeful movement. Next. Body distribution, focal dystonia. Usually adult onset having most common focal onset like cervical dystonia, torticollis, anterocollis, and that is second is segmental, more than 2 areas involved, multifocal, more than 2, non-contagious involved, and generalized dystonia when trunk plus 2 other regions is involved. And last one is hemidystonia, unilateral. So another hyperkinetic disorder case, 18-year-old female presented with 4-week history of progressive worsening of involuntary irregular movement involving the right upper limb leading to difficulty in daily activity. The movements are non-rhythmic, purposeless and disappear during the sleep. She reported a history of sore throat 2 months prior, treated symptomatically. Anyone diagnosis? Yes, these are the movement of chorias. So young female more likely cause is syndrome chorea. So diagnosis made by ESO titer positive, increase is mitral regurgitation with MS, preserved LV function. So treatment started, injection benzathine, penicillin for secondary prophylaxis, tablet haliperidol, cronazepam and prednisolone. After 1.5 months, 1.5 महीने के बाद पेशेंट को काफ़ी इम्प्रूव हो गया. Next. Another hyperkinetic movement disorder, 43-year-old male presented with 15-year history of gradually progressive, abnormal, involuntary movement, initially involving face, later spreading to neck, trunk and all 4 limbs. The movement progressively interfered with walking, eating, daily activity. History of behavior disturbance like irritability, cognitive decline present. family history is present. So what is the diagnosis? Huntington's, yes. So this is a case of Huntington's, age of appearance Huntington after the age of 40 years and presented with behavioral dysfunction, cognitive decline and abnormal movement in the form of chorea. So this patient have a Huntington's chorea. We do the test for rule out the Wilson disease and genetic study Huntington's disease mutation detection is positive. So we diagnose this case of Huntington's disease. Next. This is another hyperkinetic movement disorder. 68-year-old hypertensive female presented with sudden onset of continuous involuntary flinging movement involving right upper and lower limb. Patient alert, orientated, irregular, proximal more than distal flinging movement confined to right side, upper and lower limb. No sensory loss, cranial nerve or cerebellar sign. Diagnosis? Unilateral है, right side है, proximal more than distal है, amplitude ballistic है. Yes, this is the hemibalismus. MRI brain done. There is a left side subthalamic nucleus and adjacent posterior medial subthalamic region infarct. So acute post-stroke hemibalismus due to the left subthalamic ischemic infarct. Treatment is sodium valproate, clonazepam, haloperidol and aspirin atorva. Next. This is another case, hyperkinetic disorder. 21-year-old male presented with progressive abnormal involuntary jerky movement of all four limbs for 4 months associated with progressive cognitive decline. Immunization history not received, complete childhood immunization. Examination, sudden brief generalized shock-like jerk involving face, neck, trunk and upper and lower limb plus sustained posture of the neck. So the two movement. And these movements are periodically every 6 seconds. Of the right upper limb, you can see, and neck sustained posture. Abnormal movement usually more appear in the left side. Yes. If a periodic discharge is, periodic myoclonic jerk is present, then diagnosis is SSP. It's because due to the poor immunization of the measles. So SSP diagnosed on the basis of EEG, periodic generalized high amplitude stereotype complex every 6 seconds time locked with myoclonic jerk. And CSF elevated anti-measles antibody titer is positive. So diagnosis made SSP, subacute sclerosing encephalomyelitis. Next. So localization of myoclonus, video ही दिखा दो, discussion रहने दो. So this is another hyperkinetic disorder. You can see tics, Tourette syndrome or stereotypy. Usually is common. Stereotypy is persistent, tics is intermittent. So that is the difference, tics versus stereotypy. Tics are sudden, rapid, recurrent, non-rhythmic motor movement or vocalization, typically preceded by a premonitory arc and briefly suppressible with effort, followed by a sense of relief. Simple motor tics, eye blinking, shoulder shrugging, facial grimacing. In this patient is facial grimacing. Complex, touching, jumping, phonics, throat clearing, snapping, grunting, word phrase. Stereotypy are repeated, but that was the persistent. This was the intermittent. So this case is the Tourette syndrome. Next. This is the hypokinetic disorder. Now you can diagnose. Yes. Slow gait, slow stiff gait and rest tremor, that was the re-emergent on the examination. In this case is bilateral presentation in advanced stage. And the stoop posture, slightly neck flexed, elbow flexed. So this is the case of Parkinsoning. So idiopathic Parkinson disease require bradykinesia, at least one of the following: rest tremor, rigidity or postural instability, asymmetric onset, reduced arm strength and postural changes. Red flag if symmetry अगर then alternative diagnosis, early postural instability or falls, then alternative diagnosis consider. If levodopa not responded, that means PSP or another Parkinson plus syndrome. Early bulbar dysfunction like dysphagia, then it is a possible of PSP or MSA. So another case, 67-year-old male evaluated for 3-year history of progressive gait difficulty. His family report that began having frequent unexplained fall since last 8 months with increasing slow and stiff gait, difficulty turning during the walking. On examination, marked axial rigidity, broad base stiff gait, and when asked to rapidly look downward, vertical gaze palsy. There is no limb weakness or sensitivity. No response of the levodopa therapy. So this is a case of PSP. There is a vertical gaze palsy. So start the Parkinson syndrome. If bradykinesia and rigidity is present, then diagnosis Parkinsonism, not Parkinson disease. Parkinsonism. Minimum criteria is rigidity and bradykinesia. If asymmetrical onset, levodopa response, then it is a idiopathic Parkinson disease. If poor levodopa response, early falls, downward gaze palsy, diagnosis is PSP. If severe dysautonomia like bladder incontinence problem, then more likely MSA. Align limb extreme asymmetrical apraxia, then diagnosis corticobasal syndrome, CVGD. And dementia, early onset, visual hallucination, then diagnosis is diffuse Lewy body disease, DLB. And distinct clinical history or phenotypes, lower body only, lower limb onset Parkinsonism, that was the vascular Parkinsonism. And age less than 60, KF ring present, diagnosis of Parkinsonism, more likely Wilson disease. If recent any medication for vomiting or any psychiatric medication, then drug induced Parkinsonism. This is simple evaluation for Parkinson case. Next. This is a 45-year-old male presented with sudden onset jerky movement of the right upper and both lower limb. Movement temporarily halted by asking the patient to hold both arms in a particular position. What is the likely diagnosis? It's for audience. Okay. This is functional neurological deficit, hysterical.
Thank you so much, sir. Thank you so much for the wonderful session, sir. I would like to request our speaker, sir, and our chairpersons to please proceed to the felicitation center for the felicitation. Our next session before our inauguration ceremony would be of epilepsy. It is by Dr. Vinay Agrawal, sir. So I would like to call upon Dr. O.P. Shukla, sir, Dr. Raghavendra Yadav, sir, and Dr. Subhash Agrawal, sir, to please proceed on the dais for the chairperson. It is my privilege to introduce our next esteemed speaker for our scientific session. Dr. Vinay Agrawal, sir, is a distinguished neurologist with extensive expertise in comprehensive epilepsy care, difficult to control epilepsy, and application of evidence-based therapies. So please join me in extending a warm welcome to Dr. Vinay Agrawal, sir, from Agra. Sir.
Thank you everyone and organizers for giving me this opportunity. मेरे को जब ऑर्गेनाइजर इनका फ़ोन आया तो बोले कि हम लोग बाहर के स्पीकर भी रख रहे हैं, तो मैंने कहा मेरे से ज़्यादा अंदर का तो कोई हो नहीं सकता, मैं खुद भी पेरेंट्स एंड लॉज, तो मैं so thanks everyone for giving me this opportunity. Today I will discuss about rational polytherapy, that is using more than one medicine which is often required in epilepsy management, and it affects all the practitioners, whether it is physician or surgeon or gynecologist, because sometimes patient or an epileptic patient becomes pregnant, then it becomes very difficult कि क्या करें क्या नहीं करें. So I will try to discuss in short. So epilepsy is defined as at least two unprovoked. Unprovoked means there are no secondary causes like patient is in sepsis, hyponatremia or any metabolic disorder which are more than 24 hours apart, or even a single seizure with a high recurrence rate, like patient is having single seizure but is having a structural lesion in the brain, जैसे कि common होता है cystic sarcosis we all see, then he or she is classified as an epileptic, or a medical diagnosis of an epilepsy syndrome like juvenile myoclonic epilepsy. But why this definition is required? Because it decides which patients require treatment and which patient doesn't require treatment. Every epileptic patient doesn't require treatment with drugs. If he is not fitting into this definition, we can counsel the patient and advise follow-up. So definition is very important. And second important thing is, these drugs, whatever drugs we have right now, they can't alter the course of epilepsy. They are not anti-epileptogenic. Therefore, the classification or nomenclature has been changed from anti-epileptic drug to anti-seizure medicine. They just prevent seizure recurrence. They are not anti-epileptogenic. This is very important to know. So in my discussion also today, I will call these drugs as anti-seizure medicine only. So with this natural history of epilepsy, about 40% of patient appears permanent remission, usually with the first or second drug. Remaining patients either have delayed remission or some doesn't have relapsing remitting course, and some patients never achieve remission. They continue to have seizures. And out of these patients, certain patients are candidate for epilepsy surgery. And this is very important to know in routine practice also. My advice is, if patient is not controlled on 2 drugs, then he should be given a chance to referral to a center where epilepsy surgery and evaluation is performed. Whether he is not eligible or not, that is a secondary issue. But he should always be given a chance, because after 3rd drug, chances of epilepsy control is very less than 6%. Choice of anti-seizure medicine. To everyone's surprise, I think lamotrigine is the first choice in both focal epilepsy as well as generalized epilepsy. But we hardly see any prescription in India of lamotrigine. I don't think any physician sees, even by neurologists, they don't prescribe lamotrigine despite being the first choice. Because lamotrigine has its own problem. It is very slow to titrate. It has rashes and severe adverse effect. And in India, it is very difficult to make patient understand that your seizures will get control after 1.5 to 2 months. So they want immediate this thing. So for this, levetiracetam is the favorite drug right now for focal epilepsy, and it is again becoming a choice of drug for generalized epilepsy as well. So what to do if there is recurrence on first drug, like patient is on phenytoin, patient is on levetiracetam, or patient is on any drug, and which is very common because about 50% patient will have recurrence. So we should not jump right away to start a second drug. We should stop, analyze and rationalize. So what to analyze and rationalize? We have to analyze whether we have to look for the factors related to treatment failure, whether anything we are missing in the diagnosis or the differential diagnosis. We should look at first whether the patient even require the first drug, दूसरी ड्रग ऐड करने की बात है, पहली ड्रग की भी जरूरत है कि नहीं है. सबसे पहले ये देखना चाहिए कि कोई डायग्नोसिस वी आर नॉट मिसिंग, and then go for polytherapy. So this differential diagnosis, which we call as pseudo refractoriness, that is apparently patient की seizures control नहीं है, but current seizure नहीं होके कुछ और है. So this is a differential diagnosis which can be drug related or disease related. Most common is misdiagnosis. Misdiagnosis in which vascular is very common. Syncope is often, very often, not often, very often misdiagnosed as epilepsy. Movement disorder, Dinesh sir has very nicely presented videos, especially hyperkinetic movement disorder like chorea. They can be misdiagnosed as epilepsy as myoclonic epilepsy, which is very common. And to add confusion, both myoclonus and chorea are controlled by valproate. So the confusion again adds up. Then we have certain sleep disorder, and not to forget the psychogenic, that is hysterical seizures or pseudo seizures or paroxysmal non-epileptic seizures. In a tertiary center, they account for almost 30% of patients diagnosed as having epilepsy. They turned out to be pseudo seizure at some point. Either they have ideal true pseudo seizures or they have mixed pseudo seizures with true seizures. Inability to identify the correct type of epilepsy, this is often because we don't listen to patient. Because focal onset epilepsy is usually missed if we don't take history properly. Then lifestyle issues like alcohol, drugs and psychological issues also contributes because they not only reduces the efficacy but they also reduce the threshold of seizure. Then inappropriate drug selection, it is very common. Like if we use phenytoin in an absence seizure or myoclonic seizure, they will only exacerbate. Inadequate drug dosage, an incorrect assessment of response. That is, patient usually complain of side effect. They will return to you, almost 50% of patient return on third, fourth day कि सब चक्कर आ रहे हैं दवाई खाते ही. So to be on safer side, we reduce the dose immediately. But usually these symptoms are very transient, then they will go away. So we should not be in hurry to reduce the dose at any time. This is what I call defensive medicine, which we are practicing for last 20 years. That patient ने कहा कि symptom ठीक है, patient is always right. Non-adherence, it is also very common. So if patient, if you have any doubt, we should always assign an attendant who can give the drugs. To show these differential diagnosis, I have 2-3 short videos. This is a young kid, around 4-5 years of age. The attendants brought all these videos, their attendants have brought, and I always encourage. Look, very short, you can have this. These are very short episodes. These are classical absence seizures, which we have documented in the EEG also by 3 per second, this thing. These are very easily missed. So if any kid, damn kid, comes to you with the parents कि बच्चा साहब पढ़ नहीं रहा है, उसके स्कूल के परसेंटेज कम हो रहे हैं, भले हिस्ट्री ना दो रहा, यू हैव टू आस्क देम रिपीटेडली कि भाई इसको चौंकने ऐसा खो जाती है क्या. और एक सिंपल मैन्यूवर और है विच यू कैन डू इन क्लिनिक विदाउट ईईजी कि आस्क द चाइल्ड टू हाइपर वेंटिलेट फॉर हाफ टू 1 मिनट इन फ्रंट ऑफ यू, तब भी आप इसको प्रोवोक कर सकते हो बिना ईईजी के भी. नेक्स्ट स्लाइड कैसे है. This video helps. This is the patient on a middle-aged man, and he was having it and a sudden fall. This is classical of syncope. So videos very help a lot these days. So always encourage patients to make videos or take from CCTV cameras, because then you don't require any EEG or any such thing. Next कैसे है. These are sudden jerks which are very often missed. This is a male patient, otherwise these are very common in female patients, more common early morning jerks, which has an EEG equivalent of this myoclonic epilepsy. So it is very common. And they are also often missed. It is one of the most commonly missed epilepsy syndrome, myoclonic epilepsy. So if we have ruled out other differential diagnosis, then we will focus on today's rational polypharmacy, that is how to use the combination of drugs smartly and intelligently. This is not our interest. And interestingly, there are no approved criteria as such for which drug to use with which drug, because human studies are insufficient and they are impractical, because we can't put an epileptic patient whose epilepsy is not controlled on placebo. So we have to use our clinical decision, and we should know this pharmacodynamics and pharmacokinetics of common anti-epileptic drugs at least before prescribing them. So evaluation we have discussed in brief. Are they true seizures? Are the syndrome correctly identified? This is very important to identify comorbidities, whether patient is having liver disease, renal disease, cardiac disease. Is there any lesion? Is a patient surgical candidate? Or if patient is likely to get benefit from addition trial, after 2 drugs, we should not try much of treatment. Video EEG and MRI and specialized test. But usually EEG and specialized test are not required. What is the predictors of drug resistance? That is, we should know from start which patient is going to require multiple drugs. Most common is epilepsy syndrome, very young age of onset, neonatal seizures, focal seizures, multiple seizure type at onset, hippocampal atrophy, like we often see on MRI report, mesial temporal lobe sclerosis, which is very difficult to control. Dual pathology or inborn error of metabolism. So goal of treatment, ideal goal is to make patients seizure free, but this is always not practical. So reduction in seizure burden must also be considered. We should always take into consideration patient age, psychological status and occupational status. If he is in a high risk job, then obviously seizure control is the aim, but if he is not in the high risk job, then partial seizure control without side effects is our goal. What are the variables while choosing an optimal additional drug or anti-seizure medicine? Obviously it should be highly efficacious, low adverse effect, and it should have minimal drug interactions. And obviously in our country it should be cost effective. Otherwise, because most of the patient require it for years, he will not be able to take the drug for long. Age, in very young patient, we have to avoid drugs like valproate and phenobarbital. Compliance is very important. Comorbidities, it is very important to know. Levetiracetam, which we use day in and day out, it is contraindicated in renal patients. We should always know it, because I see many prescriptions, patient even on renal disease, they are continued to having on levetiracetam. Similarly, it's cogener, it is contraindicated in this liver disease, breveracetam. Similarly, if patient is having cardiac disease, we should never use lacosamide, which is the commonly used, because it causes AV blockage. So we should know at least common side effects of commonly used drugs before prescribing them. Concomitant medications, our aged population is mostly on anticoagulants and antiplatelets, and if we use drug enzyme-inducing drug, we should avoid them like carbamazepine, oxcarbazepine in elderly population. Epilepsy syndrome, which we have discussed, and seizure type we have discussed. So one important question is कि if patient को अगर fits आ रहे हैं, दौरे आ रहे हैं एक drug पे, तो उस drug को continue करके दूसरी drug add करनी है, उसको हटाना है. It depends. If initial drug is indicated, well indicated and has minimal side effects, then we should add second drug. If initial drug is not tolerated or is poorly indicated, then we should replace the first drug. So it decides the monotherapy versus polytherapy. A special situation, many gynecologists are sitting here, is pregnancy. In pregnancy, we always prefer monotherapy. We should always try to switch the single drug. Otherwise, teratogenicity will multiply. So when drugs are added, they can have additive effect, they can have superadditive effect or antagonistic effect. Our target is to have superadditive effect and infradditive side effect. For this goal to achieve, we should use drug with different mechanism of action, not from the same mechanism of action. And we should definitely know mechanism of action of at least 4 to 5 drugs which you commonly use. You can't prescribe without it. No drug or minimal drug interactions, no additive side effects, easy to use and well tolerated. So this may look a bit complex, but it is very simple. Basic purpose of anti-seizure medicine is inhibition at either presynaptic level, where we have 3 sodium, potassium and calcium channel, or synaptic vesicles, which inhibits the release of neurotransmitters, or at the postsynaptic level we have glutamate receptor, so which inhibits this or this will reduce seizure. Commonly acting drugs are, most of the drugs, older medications are on sodium channel, and like sodium channel are phenytoin, carbamazepine, lamotrigine and lacosamide, and for GABA, phenobarbital and benzodiazepine like clobazam, vesicles acting levetiracetam and breveracetam, and multiple action valproate. So this is very important. This slide is this boring type of slide where we have written the mechanism of action. But if we know this, the mechanism of action, these common drugs, we should always try to use from different groups. We should never use like phenytoin and carbamazepine or phenytoin and lacosamide. Otherwise, we will have an infradditive this efficacy. Best example of rational polytherapy is sodium valproate plus lamotrigine. This is in the modern day, this is the best combination for polytherapy. Others are levetiracetam, lamotrigine, lacosamide, levetiracetam, and valproate and levetiracetam. But you should never use phenytoin, carbamazepine as we have seen, or drug from the same group. Rules for optimal efficacy we have seen, already discussed, different mechanism, superadditive effect, infradditive side effect. Now every 2 to 3 years new anti-seizure medicine arrives, but to surprise, for everyone's surprise, their efficacy is almost similar. Like phenytoin and the latest cenobamate, they have almost similar efficacy. But newer drugs are easy to use, they have minimal interactions. For polytherapy, they are preferable as compared to monotherapy. Now we have 2 short cases. Is there time, sir? Can one case, this one. A 30-year-old female was having complex partial seizure. She was having right side hippocampal sclerosis. So she had complex partial seizures. She was controlled with carbamazepine, which was gradually increased up to 800 milligram per day, which is quite a good dose for Indian population. Although therapy was well tolerated, she doesn't have any side effect. Compliance was okay, but she was still experiencing 4 to 5 per day seizures per day. So it is we need to address this. So what next? First and foremost, again, before starting drug, we have to assure whether these are true seizures or it is something else. So fortunately, this patient attendant bring the video again. And it is very classical video of complex partial seizure in which we can see the patient is rubbing her hand and she is totally unaware. This is automatism of complex partial seizure and she is totally unaware. So this video helped a lot. By this, seeing this video, we can be sure that she is having true seizures. It is not pseudo seizure, and we don't require anything else like EEG or anything after seeing this video. Now she is okay. She is gone. So choice of drug in this case was good, carbamazepine. Drug level, usually it is very difficult to get. This is entirely a different topic. Compliance was adequate, tolerability was good. So what is the choice of drug? Can anyone? We have on carbamazepine, seizures not controlled, second choice. Yeah. Levetiracetam is there because it has different mechanism of action. It is indicated for focal seizures. So we put patient on levetiracetam. Her seizures were controlled. No additional side effects were maintained on both the drugs. We have one or two more cases, but due to time shortage, we'll discuss it sometime. Thank you. Thanks, everyone.
Thank you so much, sir, for the wonderful presentation. We'll now proceed for the inauguration ceremony. I'll now like to call Dr. Namrata Patel, sir, for the further proceedings.
So, good afternoon, everyone. We are heading towards one of the most important session of today. That is the inauguration ceremony of this Medicine Update Chambal 2026, which is being held on 9th of August 2026 in Morena. इस संगोष्ठी की जो थीम है, जिसको इसको जस्टिफाई करना है, ज्ञान का संगम, स्वास्थ्य का संकल्प, तो हम सब लोग इस समागम के माध्यम से अपने लोगों के लिए स्वास्थ्य का संकल्प लेकर चले हैं. एंड वी आर ज्वाइंड बाय मैनी डिग्निटरीज विथ अस. So I respectfully invite our distinguished dignitary to kindly grace on the dais our chief guest, Dr. Ashit Yadav sir, who is IPS Director, DIG, Gwalior region. I request Dr. Rathi sir to accompany our respected chief guest sir, Dr. Vivek Rathi sir, who is the organizing chairman, Medicine Update Chambal, to be on the dais. I request Dr. Pradmesh Upadhyay sir, who is CMHO of Morena district. I request Dr. Ashok Gupta sir, President of Indian Medical Association Morena. I request Dr. Meera Bandi madam, who is President of IMA Women's Wing Morena. Requesting all the dignitaries to on the dais. We warmly welcome you to this Medicine Update 2026. I request for the floral welcome Mr. Ashish Patel, Director of MKB Pharma, who has been the foundation of this ceremony, to welcome our chief guest, Dr. Ashit Yadav sir. Please give a big round of applause. Inviting Dr. Subhash Agrawal sir for welcoming our organizing chairman, Dr. Vivek Rathi sir. Dr. Subhash Agrawal sir. Sir, please come. inviting Dr. Navneet Agrawal sir to felicitate our guest Dr. Pradmesh Upadhyay sir, Dr. Navneet Agrawal sir from Gwalior. I invite Dr. Hema Singhal madam to felicitate our guest Dr. Ashok Gupta sir, who is president of IMA. Inviting Dr. Parimal Swami sir, a distinguished scientist and a very famous clinician, for felicitating Dr. Meera Bandi madam.
I would like to request everyone to please clap.
Please give a big round of applause. So चंबल की इस पावन धरती पर जहां पर हमने इस मेडिसिन अपडेट का आयोजन किया, जिसकी थीम है लर्न, अपडेट, इंस्पायर एंड डू नॉट स्टॉप हेयर, बट ऑल्सो टू इम्पैक्ट टू द privileged society we are serving. So to brief on our medicine update, I now request our chairman, Dr. Vivek Rathi sir, to deliver his welcome address and formally welcome our esteemed guest faculty and delegates to Medicine Update 2026. Dr. Rathi sir.
Thank you so much, Master of Ceremony. A warm welcome to all. With great pleasure and a deep sense of honor, I want to welcome Dr. Asit Yadav sir. He is IPS DIG Gwalior Range. To this Medicine Update Chambal 2026. Many of us might be wondering why we have invited a police officer in our doctor's meeting. I must tell you, Dr. Asit Yadav is just not an IPS officer, but also a doctor by education. He has completed his MBBS and MD in medicine with gold medal. He must have a big round of applause. So we felt that he could be the best choice for this session. And we just requested him and he has agreed to it. And on behalf of entire fraternity, we welcome you, sir. On the dais, our CHMO, Dr. Pradmesh Upadhyay sir, is there. He is very dynamic, amicable. He has always have a positive attitude. He always tries to find out the solution for any problem. Thank you for being with us. The dais is our president, IMA President Dr. Ashok Gupta sir, and IMA Women Wing President Dr. Meera Bandil ma'am is also there. We welcome you. I also extend my welcome to our eminent distinguished speakers to the historical city of Morena, known for ancient monuments like 64 Yogni ka Mandir, where we have the design of parliament is taken from this 64 Yogni ka Mandir. Another mandir we have Bateshwar, which has got hundreds of Shiv temples. You must visit if you get time. And there is a temple here, Kakanmat. It is made up of stone with no cement and no adhesive used. And it has been there for centuries, untouched. And my dear colleagues and valued participant and partner, thank you once again for being here. सपना देखना एक बात है, लेकिन सपने को जीवंत रखना और उसको वास्तविकता देना एक दूसरी बात है. और ये समय होता है जब आपकी आंखें उसको ढूंढ रही होती हैं जो आपको सांत्वना दे सके. उसकी आपके कान लालायत होते हैं उसके सुनने के लिए कि जो आपकी बात को स्वीकार कर सके और आपको सही सजेशन दे सके। एक सपना था मुरैना में मेडिकल कॉन्क्लेव करने का, और उसको साकार करने के लिए मुझे हाथ मिले हमारे MKB फार्मा के डायरेक्टर आशीष पाटिल साहब का। लेट अस गिव अ बिग राउंड ऑफ अप्लॉज टू हिम। ही हैज सपोर्टेड इन एवरी वे। मुरैना में मेडिकल अपडेट करना बहुत आसान नहीं था, इसमें तरह तरह के अवरोध आए, लेकिन समय समय पे हमारी मेडिकल जो भी मैनेजमेंट टीम थी, ऑर्गेनाइजिंग टीम थी, उसने उसको रिजॉल्व किया और आज अपन इसको कर पाए हैं। थैंक यू फॉर बीइंग विद अस एंड थैंक यू IMA फॉर ज्वाइनिंग अस। Medicine Update Chambal is more than just an academic event. It's a platform to exchange knowledge, share experience, and strengthen our collectiveness, commitment towards the patients, and to make the community more healthier. We are privileged and honored to have a rainbow of eminent speakers with us today. They would be speaking on different topics of medicine. As Dr. Puneet Rastogi sir is here, he will be talking about cardiology. Dr. Ajay Gaur will be talking on dengue. Professor Narmada Patel and Dr. Navneet Agrawal has spoken on diabetes. Professor Vrinda Joshi, as usual, a good teacher. She spoke about PIH and made the gynecologist more clear about the treatment and management. Dr. Udainia sir, Dr. Khandelwal, Dr. Vinay Agrawal from Agra, and many more will be discussing different medical issues today. They are all from various parts of the India. Some are from Bhopal, Jabalpur, Indore, and to mention from Gwalior and Agra too, whose presence will enrich the discussion and inspire the new perspective. And we will have been enjoying this since morning. A good discussion was there. Many queries which we had were resolved, and still they persist, which will be resolved in the lunchtime. So once again, I extend my heartfelt gratitude to all our speakers, delegates, partners, and supports. We are here to learn, to imbibe, and to grow together. I welcome some of the doctors, my friends, my batchmates from Gwalior. They also have come. Thank you. Thank you for being here. Once again, you are welcome. Thank you very much.
तो हमारे चंबल रीजन के लोगों के स्वास्थ्य के संकल्प के साथ जब हम चल रहे हैं, तो 2047 का मिशन जो मोदी जी ने देखा है और हम सब लोगों के दिलों में है, उसको साकार बनाने के लिए हम लोगों की कुछ योजना अपने स्तर पर चल रही है, जिस टीम को लीड कर रहे हैं डॉक्टर विवेक राठी सर। और इसी श्रृंखला में हमारे वो चिकित्सक जिन्होंने अपने जीवन के अमूल्य समय को इस रीजन की सेवा में समर्पित किया है, बारी है उनको सम्मानित करने की। इसी कड़ी में हम लोगों ने इस मंच से अवार्ड डिक्लेरेशन की है, जिसमें चंबल रत्न जो इनका सर्वोच्च अवार्ड है की घोषणा कर रहे हैं। और मैं रिक्वेस्ट करूंगा कि आपकी तालियां रुकनी नहीं चाहिए जब मैं अवार्ड अनाउंस करूं। एंड आई रिक्वेस्ट ऑल द डिग्निटरीज टू हैंड ओवर दीज अवार्ड्स टू द रेसिपिएंट्स। द अवार्ड ऑफ चंबल रत्न goes to Dr. O.P. Shukla sir. Please give a big round of applause. It is our pleasure and privilege to have him here. He has dedicated all his life to the region of Chambal. Requesting the support staff to सर को नीचे जाके अवार्ड दे सकते हैं सर। सर आएंगे ऊपर प्लीज। Please give a big round of applause. In the same series, we have 3 Lifetime Achievement Award. A very prestigious Lifetime Achievement Award goes to Dr. Harilal. Dr. Harilal sir, devoted decades of service to this region of Chambal, requesting the organizing team to award Dr. Harilal sir with the prestigious award. If he has got some difficulty in moving, we can provide them at his place. So thank you, Dr. Harilal sir, and congratulations on this Lifetime Achievement Award. Next in the series, Dr. Ravi Maheshwari. Dr. Ravi Maheshwari, who is a pathologist, has devoted his life in the service of this region, diagnosing many pathological conditions by virtue of clinical skills. Requesting Dr. Ravi Maheshwari. Requesting the dignitaries to please come on the dais. Requesting the dignitaries to please come on the dais. Rest of our recipient can have their awards from the stage, sir. So, Dr. Ravi Maheshwari, please be on the stage, sir, for Lifetime Achievement Award in the field of pathology and medical science, the service to humanity. The third Lifetime Achievement Award goes to Dr. S.M. Agrawal sir, who is an eminent surgeon in the Chambal region. Dr. S.M. Agrawal sir. Sir, please be on the dais. The Lifetime Achievement Award to Dr. S.M. Agrawal being given by our eminent guest. Please give him a big round of applause. Because of paucity of time, I will be little fast in the next award. So it's a matter of great privilege announcing award to one of my closest friend. This is a community service award to respected Dr. Raghavendra Singh Yadav, who is a clinician in city of Morena, doing an excellent job. Dr. Raghavendra Yadav, please come on the dais. Congratulations, and please give him a big round of applause. Next in the series, Dr. M.P. Gupta sir. Dr. M.P. Gupta sir, for Community Service Award. Dr. A.K. Gupta sir. Dr. M.P. Gupta, Dr. A.K. Gupta sir, for Community Service Award. Sir, please come on the dais. Congratulations to you. Please give him a big round of applause. तालियां रुकनी नहीं चाहिए. Thank you, sir. Dr. A.K. Gupta, sir. Dr. Sanjay Sharma, sir, who is a dentist practicing in the region of Chambal, for Community Service Award. He is not here. Dr. Yogesh Tiwari, sir, who is an important part of our organizing team. Dr. Yogesh Tiwari, sir, from Morena. Next in the series, Distinguished Physician Award or Young Achiever Award. Please give a big round of applause. So the Distinguished Physician Award, Young Achiever Award goes to Dr. Sanjay Rajput from practicing orthopedics. Dr. Sanjay Rajput sir, please come on the dais. Dr. Yogendra Yadav sir. Dr. Sanjay Rajput, Dr. Yogendra Yadav, Young Achiever Award. Dr. Sharad Sharma sir, who is a surgeon. Please come on the dais. Dr. Shashank Gupta. Dr. Shashank Gupta sir, please come on the dais. Dr. Ram Prakash Sharma sir, for Young Achiever Award. Please give him a big round of applause. तालियां रुकनी नहीं चाहिए. Please give a big round of applause. And a very, very important award, last in the series, the award for outstanding contribution to women's health. The award for outstanding contribution to women's health. And you can see a lot of lady doctors contributing to this CME and medicine update. तालियां रुकनी नहीं चाहिए. The award for outstanding contribution to women health goes to Dr. Meera Premi. Requesting madam to please come on the dais. Please give her a big round of applause. It's a matter of great pride for us to award the awardees. So in the same series, the award has been finished, sir. I request our chief guest, sir, to address the gathering and give us the words of wisdom. Requesting our chief guest, sir, to please come on the dais, sir. Thank you.
Thank you very much. Most of the people present here are senior to me in some way, तो मैं words of wisdom तो क्या दे पाऊँगा आप लोगों को. तो फर्स्ट ऑफ ऑल आई वुड लाइक टू थैंक राठी सर और जो यहाँ की पूरी इसकी ऑर्गेनाइजिंग टीम है IMA who have invited me to this program. सर ने इंट्रोडक्शन दिया था कि मैं एक IPS ऑफिसर भी हूँ, पर जैसे बताया था कि आई कंप्लीट माई MD इन मेडिसिन फ्रॉम GSVM कानपुर. तो ये क्वेश्चन जब कभी व्हेनेवर आई गो टू अ प्लेस, हर कोई पूछता है कि डॉक्टर्स और पुलिस में क्या सिमिलैरिटी होती है. तो जैसे एक बड़ी चीज़ है ना, इंटरव्यू में हम बोलते थे कि सेव एंड सर्व द ह्यूमैनिटी. वो तो सब करते हैं, पर दिक्कत क्या होती है कि पुलिस की भी आपको पता है बीच बीच में रेपुटेशन प्लस माइनस होती रहती है. एंड सेम गोज विद द डॉक्टर्स ऑल्सो. पर हम लोग कोशिश करेंगे कि 90% लोग अच्छे से काम करें इन माई डिपार्टमेंट, इन योर फील्ड. तो जो दोनों डिपार्टमेंट हैं, जिसको लोग कहते हैं ना कि या तो बुरे समय में पुलिस याद आती है, डॉक्टर्स याद आते हैं. तो आज की जो एक कॉन्फ्रेंस है ये इसलिए इम्पॉर्टेंट है क्योंकि मोरेना को मैंने कोविड टाइम पे देखा. कोविड एक कभी मेरी जो CHMO साहब हैं, आई वॉज हैविंग अ कन्वर्सेशन विद हिम. जिस समय कोविड हुआ यहाँ पे सिर्फ डिस्ट्रिक्ट हॉस्पिटल में सिर्फ 2 डॉक्टर्स थे जो डिस्ट्रिक्ट हॉस्पिटल में थे. एक डॉक्टर राघवेंद्र यादव थे, एक डॉक्टर तिवारी थे. और उस समय इन दोनों लोगों ने जितना मतलब आउट ऑफ वे जाके लोगों की हेल्प करी, तो वो सब लोग याद करते हैं. और ये कोविड ही एक ऐसा चैलेंज था जिसमें पुलिस ने भी एक आम जनता के बीच में एक जो रिस्पेक्ट है वो कमांड करी. तो इसलिए दोबारा से ये कहना चाहते हैं कि हम दोनों का जो जॉब है बड़ा नोबल प्रोफेशन है. इट्स अ नोबल प्रोफेशन और हमें उसको वी हैव टू लिव अप टू इट. आज की जो कॉन्फ्रेंस थी, इसका जो थीम था कि लर्न एंड देन प्रोग्रेस टुगेदर, बहुत अच्छा है. बिकॉज मोरेना में हमने देखा है कि डॉक्टर्स जैसे रूरल एरिया 80% है, ज़्यादातर जो डॉक्टर्स है वहाँ पे उनको जो प्रॉब्लम्स हैं लोगों की, एज अ पुलिस ऑफिसर क्योंकि एक पब्लिक जॉब है, हर तरह के लोग आते हैं, उनकी प्रॉब्लम्स भी होती हैं. तो जो डायग्नोसिस का लेवल है, तो समाओ कि लोग फोर्स होते हैं कि टर्शरी हेल्थ सेंटर जाएं या दिल्ली जाएं. तो जैसे कॉन्फ्रेंस है, क्योंकि इसमें काफ़ी सारे अभी जो मैं न्यूरोलॉजी का प्रेजेंटेशन देख रहा था, तो मैं अपनी पुराने समय पे, क्योंकि हैरिसन जो पढ़ी थी मेडिसिन में, देख सोच रहा था कि मैं कितना रिमाइंड करूं, और 20 साल हो गए तो दिमाग पे टफ पड़ रहा था काफ़ी। तो नाम तो याद आ रहे थे, हंटिंगटन्स और ये सब जो थे, पर 20 ईयर्स इज़ अ बिग टाइम। तो आप लोग क्योंकि अभी एक्टिव फील्ड में है, तो मैं न्यूरोलॉजी वाला प्रेजेंटेशन देखा, एपिलेप्सी वाला देखा, अब मेरे ख्याल से कॉन्फ्रेंस में कुछ ना कुछ आप लोग लेके जाइए। मेरे ख्याल से जो नॉलेज है जितना शेयर करेंगे उतना अच्छा होगा। और जो मुरैना की यहाँ पे जनता है, जिसको, जो मेरे ख्याल से बहुत ज़्यादा बाहर नहीं जा सकती या इंश्योरेंस नहीं है, तो उनको अगर हम बेस्ट हेल्थ फैसिलिटीज़ यहीं पे प्रोवाइड करें और इस कॉन्फ्रेंस का लाभ लेके, तो बहुत अच्छा होगा। धन्यवाद। जय हिंद, जय भारत।
Sir, you rightly said, the purpose of education is to change the perception, change the belief, change the practice. So thank you, sir, for your kind words. For vote of thanks, I may now invite Dr. Ashok Gupta, sir, for same. Thank you.
थैंक यू डियर। मुझे यहाँ वोट ऑफ थैंक्स के लिए बुलाया गया है। मैं अपनी बात शुरू करने के से पहले 2 पंक्तियाँ कहना चाहूँगा। मैंने एक खत दोस्तों के नाम क्या रख लिया, हर पास से गुजरने वाला आदमी पूछता है बता इस इत्र का क्या नाम है। दोस्तों में जो खुशबू होती है वो कहीं नहीं मिलती है। आज का इस भव्य कार्यक्रम के हमारे मुख्य अतिथि डॉक्टर असित यादव, आईपीएस डीआईजी चंबल डिवीज़न, जो आज हमारे बीच आए हैं और उन्होंने जो हमारा अमूल्य समय इस सदन को दिया है, मैं उनका और मेरी पूरी टीम की तरफ से, ऑर्गेनाइजिंग टीम की तरफ से, आईएमए की टीम की तरफ से मैं उनका बहुत बहुत धन्यवाद करता हूं, तहे दिल से उनका शुक्रिया अदा करता हूं। और इस सदन में जो भी स्पीकर आए हैं उन लोगों का भी मैं एक एक करके नाम पढ़ना चाहूँगा, जो आए हैं बाहर से, जगह अलग अलग जगहों से। ये जो है एक एक करके मैं पढ़ता हूँ। डॉक्टर अक्षत पांडे, रोहित खंडेलवाल, परिमाल स्वामी, प्रमेश जैन, अभिषेक श्रीवास्तव, प्रोफेसर वृंदा जोशी मैडम, नवनीत अग्रवाल, डॉक्टर मयूर अग्रवाल, नम्रता पटेल, दिनेश उदैनिया, डॉक्टर विनय अग्रवाल, इन सब का भी इन्होंने अमूल्य समय दिया है और इन सब का भी मैं बहुत बहुत धन्यवाद मेरे सदन की तरफ से भी और आईएमए टीम की तरफ से भी इनको बहुत बहुत धन्यवाद करता हूँ। इस अभी 4-5 लेक्चर और बचे हुए हैं, इस अभी ये पूरा इवेंट पूरा नहीं हुआ है, जिसमें अभी डॉक्टर पुनीत रस्तोगी, डॉक्टर अजय गौड़ दिखाई नहीं दे रहे हैं मेरे को, अभी आए नहीं है क्या? हाँ, आएंगे। डॉक्टर अजय गौड़ और डॉक्टर विवेक रंजन एंड डॉक्टर मुकेश चंगालू, इन सब का भी मैं बहुत बहुत धन्यवाद एडवांस में देता हूं कि इन लोगों ने भी अपना अमूल्य समय यहाँ पर दिया और इस मेडिसिन अपडेट को सक्सेस बनाया। इस तरह का इवेंट मुरैना में पहली बार हुआ है और उसके लिए जितने भी लोग हैं और आईएमए की टीम है, आईएमए के सदस्य हैं और इस सदन में जितने भी लोग उपस्थित हैं उनको मेरा बहुत बहुत धन्यवाद। धन्यवाद। जय हिंद, जय भारत।
Requesting all of you to please stand up for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तब शुभ नामे जागे तब शुभ आशीष मांगे, गाहे तब जय गाथा। जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे। भारत माता की, भारत माता की, भारत माता की। Thank you everyone. I request you to join for lunch. Thank you very much.
इसे हटा दें। है कौन सी एक ही है ना आएगा
ऑडियो तो नहीं है सर
वो पास कर लीजिए वो पास कर लीजिए कंटिन्यू चलिए
कौन सी है सर?
तो बस ये देखो कनेक्ट हो रहा है कि नहीं।